Hello, good morning, everyone.
Morning.
Welcome to our 2021 Women in Epilepsy Conference. If you haven't taken the poll, go ahead and take the poll. We're going to kick things off here. All right, so thank you guys. Thanks for joining us this morning. My name is Missy Dalloway. I am the president and CEO of the Epilepsy Foundation Eastern PA. We're so happy to have you join us this morning. Just some kind of housekeeping notes so that you're aware of. Your camera and your mic will be turned off and muted for the entirety of the conference. So you can go ahead and kick back and relax and enjoy your coffee because there won't be any cameras on or mics on. You'll notice that there's a chat box at the bottom of the screen. Any questions that come up as we're going along today, go ahead and drop those questions right in the chat box. You won't be interrupting any speakers. We'll hold all questions until the end of each presentation. And then our moderator will go through them and your questions will be asked to the speakers. So as things come to you, go ahead and put it in that chat box. Also feel free to just say hello and good morning through the chat box as you see happening there. We're happy to have you join us. So as you see on this screen here, when it comes to epilepsy, you are not alone. Epilepsy is so frequently regarded as a rare disorder, but as you see with some of these stats and figures on the screen, it's actually quite common. 1 in 10 people will experience a seizure at some point in their lifetime. 1 in 26 people will be diagnosed with epilepsy. So, you know, it's much more common than people really tend to think about epilepsy. And we believe that's really because so many people don't talk about living with epilepsy and what they go through having epilepsy. So we're here to really try and change that. 110,000 people in Eastern Pennsylvania alone are living with epilepsy, and an estimated 3.4 million people in the United States have epilepsy. So a lot more common than most people tend to think. But as I said, we're here to change that and really educate the general public. So a little bit about us. We are the Epilepsy Foundation Eastern PA. We've been here for you for the last 49 years. We serve the 18 counties of Eastern Pennsylvania. Our office is headquartered in Philadelphia, but we have resource coordinators living and working directly in their communities, all the way up in the Wilkes-Barre-Scranton area, the Lehigh Valley, out to the Lancaster-Berks area, and everywhere in between. So we are here to serve and support you. Our mission is to stop seizures and SUDEP, find a cure and overcome the challenges created by epilepsy through efforts including education, advocacy, and research to accelerate ideas into therapies. So what that means is that we are here to serve and support our local epilepsy community by offering a wide range of support services, resources, and programs. We're here to empower and improve the lives of local families and individuals affected by epilepsy, and our goal is to help you overcome the challenges of epilepsy so that you can live your very best life. And we are firm believers that education is one of the most important pieces of accomplishing that goal. So again, we're really happy that you're joining us and you are taking those steps to further your epilepsy education. And I'm glad that we're doing it all together. So as I mentioned, we offer a wide range of free support services, programs, and resources. You'll see a bunch detailed on the screen here. Seizure recognition and first aid trainings. I think that that's one of the absolute most important things that we do at the EFEPA. We go into the schools to lead these trainings with teachers, school nurses, students, personnel. We lead seizure recognition and first aid trainings with first responders and law enforcement. We'll come into your workplace to lead these trainings with your employees. Wherever our trainings are needed and requested, we are more than happy to help, and we love leading these trainings. So please let us know if we can set that up for you. We offer monthly support group meetings all throughout our region. Those are currently still being held virtually. So there's a really great calendar of support group meetings that you can pop into as they fit in your schedule. We're here for you as your advocacy partners. Our resource coordinators will meet with you one-on-one to provide information and referrals and be an epilepsy advocate for you however you might need one. We host a lot of really great community and awareness events. We have 4 regional Walk to End Epilepsy events. We do our annual Mardi Gras Gala. We plan tons of awareness efforts all throughout the month of November for Epilepsy Awareness Month, as well as throughout the year. So that's a great thing that you can get involved in. We offer a wide range of educational conferences and webinars all throughout the year, such as this one that you're joining this morning. We also have our 2 conferences coming up less than a month away in May, our Pediatric Epilepsy Conference, as well as our Adult Epilepsy Conference. My friend Rena is going to tell you a bit more about those at the end of the program today. We offer a wide range of youth and young adult services. Our resource coordinators can assist with IEPs and seizure action plans and accommodations. We have our monthly Youth Achieve meeting. We have a really great Young Friends of the Foundation group. We're also currently running a brand new transition workshop webinar series. That's every Tuesday evening through May 18th. We offer programming on topics to help young people living with epilepsy navigate that transition from adolescence to adulthood. So another great thing to get involved in, or to get your child involved in. We offer our very favorite Camp Achieve. That's our week-long sleepaway camp for children ages 8 to 17 living with epilepsy. We also offer our young adult retreat, which is coming up Friday, May 21st to Sunday, May 23rd, as well as our adult wellness weekend for that next age group of 30 plus. That's every September. So again, a really wide range of some really great programs and services that are available to you. We're here to help you any way that we can. So please reach out to us. Let us know how you'd like to get involved and how we can, best be a partner for you in your fight against epilepsy. So moving on from here, I wanted to take a moment to recognize and really spotlight some of our incredible partners who really make our work possible. So first and foremost, we have Greenwich Biosciences, who is our presenting sponsor today, but also across every conference and webinar that we offer throughout the year. We're really grateful to Greenwich Biosciences for all of their generous support in really making our work possible. And so with that, I'd like to introduce my friend Courtney to say a few words about Greenwich Biosciences.
I might have help. My son may try and talk with me, but good morning, everyone. My name is Courtney Jograd, and I'm honored to be speaking with you virtually today on behalf of Greenwich and our entire team. As a sponsor of this event, Greenwich Biosciences is proud to partner with the Epilepsy Foundation of Eastern PA. You've all probably seen me before. I love the Epilepsy Foundation of Eastern PA. I love what they do. I love the energy that they put in terms of creating great programs like this. So we are all united in what we're trying to accomplish here today, which is to raise epilepsy awareness and to have a positive effect on care, research, lives of those who are impacted by seizures. Honestly, there's just so many families who wake up every day to the reality of epilepsy. There are people listening to this right now who've been fighting against epilepsy their entire life, and there are others who are not able to join us today. But as a community, we never give up. The hope that one day we'll all overcome the challenges of living with this disease. That's what drives us. So you may know us as the company researching and developing FDA-approved cannabinoid medicines to help address serious conditions, but just know that the focus is you. Parents, families, they're really at the center of everything we do. So we strive to make a positive and meaningful difference in lives, in your lives. So today and every day, we're just proud to be here with you virtually and in real life to raise awareness, take action, and continue the fight of epilepsy. So have a great virtual meeting today. Thank you for all those who are participating. Thanks for all the time that you've given us, and anything we can do to help. We're always here. So have a great meeting. Thanks again.
Thank you, Courtney. He has the cutest kids. We definitely appreciate the cameos and the giggles. So next, I wanted to give a big thank you to our conference series sponsors, ASI and UCB. These companies are sponsoring our 6 regional conferences that happen throughout the year. Again, we are so grateful for their generosity and for all of their help in making our work possible. And now I'd like to introduce Nicole to say a few words about ASI.
Thank you, Missy. Thank you, everyone, for joining this morning. We're super happy to be here. Congratulations, EFEPA, on your longevity of 49 years. Can't wait to celebrate at the 50th anniversary next year. So please keep me on the invite list for that one. At ASI, human healthcare is our goal. We give first thoughts to patients and their families and helping to increase the benefits healthcare provides. As the U.S. pharmaceutical subsidiary of Tokyo-based ASI Company Ltd., we have a passionate commitment to patient care that is the driving force behind our efforts to discover and develop innovative therapies to help address unmet medical needs. To learn about our commitment, please visit www.advancingepilepsycare.com. To learn more about ASI, please visit us at www.eisai.com/US and follow us on Twitter and LinkedIn. I'm glad to be here this morning with everyone.
Thank you, Nicole. Next, I'd like to introduce our next conference series sponsor from UCB, our friend Mindy.
Good morning, everyone. Good morning, Missy. It's so good to see so many familiar faces. I wanted to introduce myself. My name is Mindy Reebstein, and I work for UCB. And our ambition and our commitment is to transform the lives of people living with epilepsy. We're so proud to support this event and participate alongside everyone today. However, our support does not end here. We are committed to advancing research to improve the lives of people living with epilepsy and finding solutions to help patients live at their ideal. Thank you for your participation, engagement, and voice. You refuse to let this disease get the best of you, and we are so inspired by your resilience. Know that we at UCB are here to support you along your journey. Remember that you're not alone. Keep your heads high and do not back down. We, along with your friends, family, and loved ones, are here for you. Thank you for including us.
Thanks so much, Mindy. Next up, I wanted to take a quick moment to give a big thank you to our vendor sponsors this morning who are sponsoring our Women in Epilepsy Conference. We have Neurelis, SK Life Science, and Supernus Pharmaceuticals. So I'd like to introduce our friend Julian from Neurelis to say a few words.
Hello, good morning, Missy and Seamus, Arena. Thank you for having me this morning. I'm so glad to see everybody, and thank you for all the participants that are here today. We're going to have a great conference lined up. My name is Julian DeLeam, and I'm the territory manager here in Philadelphia for Neurelis. Neurelis is a new company, but it's an innovation-driven neuroscience company that provides a differentiated approach to these unmet clinical needs. Specifically, epilepsy is one of them. Our application of novel technologies is designed to enhance therapeutic benefit and patient care. We're committed to improving the lives of individuals living with epilepsy and their care partners. Our passion at Neurelis is inspired every day by those living with epilepsy, their families, and the clinicians who are constantly encouraging us and expecting us more of the pharmaceutical research that we're doing. So I want to thank you for your participation today in this event. I want to thank the Epilepsy Foundation, especially Misty and Seamus and Rena, for allowing us to be here. And I'm just looking forward to a great event, and want to thank everybody for their participation.
Thanks so much, Julian. We're grateful for your partnership. And last but not least, I wanted to invite my friend Stephanie from SK Life Science to say a few words.
Good morning, everyone. How are you? Last but not least, so I have 2 teenagers, so you won't hear any of them running around in the background because they're still sleeping and will probably be sleeping till noon. So I miss those days. But thank you so much for having me. My name's Stephanie Waninger. I'm the Philadelphia Territory Manager for SK Life Science. We're a relatively new company to the United States, but so happy to be a part of all of this. So those of you who don't know, we promote once daily Xcopri. So this is a prescription medication used to treat partial onset seizures in adults 18 years and older. SK Life Science is a subsidiary of SK Biopharmaceuticals, and it's an innovative global pharmaceutical company focused on research, development, and treatment of CNS disorders. We do have a pipeline of 8 compounds right now in development for CNS disorders, including epilepsy, as I mentioned, Xcopri. So just so happy to be a part of all of this. I love that we can help the community and help those patients out there who continue to have seizures. And I look forward to the conference. So thanks for having us.
Wonderful. Thank you all so much again for all of your partnership and support. You really do make our work possible, and we are so grateful for that. Next up, it is my absolute pleasure and honor to introduce a wonderful friend and partner of the Epilepsy Foundation Eastern PA, Dr. Joyce Liberace. She is the chair of our Women in Epilepsy Conference. She has been an integral part of planning and running this conference since its inception, which I believe we said dates back to the 90s. So Joyce has just been a fantastic partner, and this is a real passion of hers. And so she ensures that every other year, our Women in Epilepsy Conference is the absolute best and strongest that it can be. So a bit about Joyce. Dr. Joyce Liberace is a general neurologist at Penn Neurosciences in Radnor, PA. She graduated from Johns Hopkins Medical School and then completed her neurology residency and fellowship in clinical neurophysiology and epilepsy at the University of Pennsylvania. She has an expertise in women's health and epilepsy. She currently serves as a member of the board of the Epilepsy Foundation of Eastern PA and also serves on the professional advisory board. Her clinical goal is to listen to patients, make an accurate diagnosis, and provide an individualized treatment plan. She has a keen interest in global health and has traveled to Africa, as pictured, to provide medical care to the people of Tanzania. She hopes to return to traveling soon. Oh, don't we all? Without further ado, let me pass it off to my friend Joyce.
Thank you very much, Missy. It's lovely to be here. This is a wonderful conference. We are an inclusive conference. It is a Women in Epilepsy conference, but everyone is welcome. And I'm a firm believer that knowledge is power. And the goal today is for everyone to learn something new through this network of education and support. Next slide. Here's our conference schedule. We'll just go briefly through this. So at 9:15, we'll have a Women in Hormones talk. All of the talks will be followed by 10 minutes of question and answer and then a quick 10-minute break. After the hormone and women's talk, we'll be planning pregnancy. And following that, next slide, will be bone health, nutrition, and vitamins. And we will be ending with a very important topic of managing stress during the pandemic. And we all, of course, need that. So really appreciate you being here. Next slide, please. As I said, knowledge helps to eliminate stigma. As you are all aware, there's a lot of stigma associated with epilepsy. Ancient people actually thought that seizures were caused by evil spirits or demons, and priests attempted to cure people with epilepsy by driving out the demons with magic and prayers. Luckily, this view was challenged by physicians dating back to Atreya of India and later Hippocrates of Greece, who recognized that seizures really were a brain disorder. Next slide. And quickly, on this slide are some famous people with epilepsy. And as I was putting the slide together, of course, I knew about Leonardo da Vinci and many people on this slide. But I actually didn't know that Tiki Barber, football player, had epilepsy, or Patrick Dempsey, one of my favorites on Grey's Anatomy. And then, of course, Chief Justice John Roberts has epilepsy because he's had recurrent seizures. So hopefully you'll see some names on here that you recognize. Next slide. Now it is my pleasure to introduce our first speaker, Dr. Allison Picard. She is a clinical associate professor in the Department of Neurology at Jefferson University Hospitals. She completed her medical school training, neurology residency, clinical neurophysiology and epilepsy fellowship training at Jefferson before joining the faculty. She serves as director of the long-term EEG monitoring unit at the Center City campus. Her clinical interests include surgical epilepsy and ICU EEG, and please join me in welcoming her today.
Okay. Hello and good morning. Thank you very much for the invitation, for asking me to speak. I'm very happy to be here. I will be talking about the women and hormones. So we'll be looking at epilepsy and how it interfaces with not only hormones, but how the two together can impact women really throughout their life in terms of the menstrual cycle, birth control, and then how the symptoms we can get and syndromes through premenstrual syndrome, PMS, polycystic ovarian syndrome, and then menopause as the hormones begin to go away in the later years of our life. So what are hormones? I always think of them as messenger chemicals. There's several different ones throughout the body. Different organs in the body produce different ones. The ones we'll be looking at today are from the ovaries. So down here, we see the estrogen and progesterone. They're made from cholesterol, and then the body forms it into these new hormones that help signal both nearby organs as well as something up into the brain, and it can begin a cascade of signaling down to enact changes in the body. So first, estrogen. For those of you chemically inclined, there's its makeup. We can find that estrogen can often make seizures more likely, and it does this through exciting brain cells. Some studies in the past have actually done a proof of concept of this, and in animal studies, they were able to increase branching of the neurons and help form new connections in the brain by putting estrogen right onto the neuron itself. So here's a picture of this. This little blob here is the center of a neuron. And here we see all the branches that exist in a normal, healthy neuron. Then they added estrogen and tracked it over time. All these little extra white arrows along the way are new branches that form. And notice it does it pretty quickly, like over about an hour and a half. So that's pretty remarkable. Progesterone, again, its chemical makeup there, does the opposite of estrogen. It can actually wind up making seizures less likely. It does this by increasing brain cell inhibition, therefore making it a little bit harder for some of those new connections or branching maybe to be formed. And it's also been proven that it can actually decrease the estrogen branching, as we see with those prior studies. So these two hormones play tremendous roles in the menstrual cycle. The menstrual cycle itself is made up of 3 phases. First, we have the follicular phase. So that's where estrogen starts to increase. The luteal phase, where progesterone instead starts to increase. And then the menstrual cycle, which we all know as the period, has decreased progesterone as well as bleeding. I always like to look at things through pictures and graphs. So we'll take a look at those 3 phases. So first, estradiol. We see it increasing up in the first 14 days of the menstrual cycle. This is the follicular phase. And here at the top in the ovarian cycle, we see in the ovary a growing follicle. This little bit here will ultimately be the egg that gets released. And over time, the estradiol or the estrogen peaks. And as it's one of its ways of signaling, signals the brain to release luteinizing hormone and follicle stimulating hormone. This causes the growing follicle to release the egg. And then the estrogen or the estradiol has done its job, so it starts to decrease. Now we've entered the luteal phase. Once the egg is released, the remainder of the follicle does become the corpus luteum. That's what produces a lot of this progesterone. So once it's present, progesterone starts to get present. Hence the luteal phase. Over time, this doesn't last forever. And so we see progesterone to start to decrease and go away. And as it does that, we enter the last phase, menses or the period. So hormones go away and bleeding occurs. So a lot of hormone changes happen throughout the menstrual cycle, and sometimes seizures can be linked to these hormones and these changes. And we call this catamenial epilepsy. We find this often more common in temporal lobe epilepsy for reasons we don't always know why. So we see hormone changes. We see a big one here. We see estrogen increasing. And then here we see progesterone decreasing. So remember, estrogen increasing, that can excite neurons, can therefore, conceptually make seizures maybe a little bit more likely to happen. Or we can see progesterone decrease. So that inhibition preventing seizures from happening goes away. So it's a double negative, but can therefore make seizures a little bit more likely. So catamenial epilepsy, we can see three different forms of it. So seizures increase in estrogen at ovulation, seizures with that drop in progesterone at menstruation, and then there's also one I haven't talked about yet. So seizures during the second half of the menstrual cycle, if anovulation occurs. So what is anovulation? It's a menstrual cycle without ovulation. So no egg is released from that growing follicle. And therefore, there's no corpus luteum, and therefore no progesterone is formed. 10% of the time in healthy women, this can happen. In women with temporal lobe epilepsy, it actually is a little bit more common, up to 35%. So back to my favorite picture here. And this is this phase here. So this is the phase we're talking about. We don't have a corpus luteum, we don't have the progesterone. So we can actually wind up seeing seizures become a little bit more likely through the second half, about a 2-week period of the menstrual cycle. So that can lead a woman who experiences seizures and epilepsy to ask, do you have catamenial epilepsy? The best way to do this and to help figure this out is to track seizures and then also track the menstrual cycle. SeizureTracker.com is a great resource. I often advise my patients, whatever method works best for you, because you'll start to see patterns that line up. If every month, right at the time of the menses is when seizures may be more likely to happen, it's certainly possible that catamenial epilepsy is present. And then you and your doctor can always look for one of those 3 patterns and discuss treatment options once this pattern might be identified. So what do we do for this? Well, we can increase the regular seizure medications around the time of increased seizures to give a little extra protection. This might beg the question of, is it possible that there's a drop in medication level during this time? And there may be, just in the way of changes in metabolism. And if increasing regular seizure medications isn't a great option, there's side effects, something like that. Progesterone supplementation can also be used. One of the best forms is just natural progesterone in the form of prometrium. However, the best dosing and timing isn't totally known with this. Some patients respond very well to dosing right around menstrual cycle. Others will take it daily. Now, throughout life, a major part of a woman's life can be family planning. And when undergoing family planning, there are several different options. I'll throw abstinence on there, but as well as condoms as a burial protection. But we'll be talking mostly about the last 3 because they are often interacting with hormones as well as giving hormones themselves. So oral contraceptions, which we all know as the pill. progesterone implants and injections, and intrauterine devices. So this picture here. With oral contraceptives, there can be combined estrogen and progesterone, or progesterone only. So notice it's the same hormones that we've already talked about. Oftentimes it comes in a 28 pill pack, 3 weeks of which is the hormones, and then 1 week is no hormone, but maybe some iron or some extra things to help support the menses part, the bleeding. So seizure medications can make low-dose birth control less effective. And I'm going to highlight this in particular because it's something that not a lot of physicians necessarily know or recognize unless they are seeing several epilepsy patients. Prescribing birth control can be very common for many physicians, but the interaction between that birth control as well as any seizure medications is a little bit more specialized. And so often I encourage my patients to know and understand how these medications can interact, to act as their own advocate when choosing new medications. So medications that affect the pill, we see a list here. Several of these are some of the older medications that work on many different receptors in the body. However, notice something like Aptium, which can be a little bit more newer of a medication. And here we have some medications that do not affect the pill, meaning birth control will still be just as effective. So levetiracetam, very commonly used, lincosamide. I have starred here both lamotrigine as well as valproate. And the reason I've done that is because instead of the seizure medication impacting birth control, the birth control pill can actually impact the medication. So oftentimes we can see the blood level of the lamotrigine in someone's body can drop with using estrogen-containing birth control. So when this happens, the drug level drops and seizures may be more likely to happen. The risk is increased. Now, we talked about birth control. There's that 1 week where there isn't hormone. So during that time, the lamotrigine level in the body can therefore increase during that hormone-free week, and that may increase the risk of side effects from the medication. So what do we do about this? We can check blood levels and follow the changes, and can sometimes adjust the dose appropriately. I often tell a story. One of my patients, a young woman who I was treating for epilepsy, had been well controlled on lamotrigine for several years. She was at a pretty hefty dose of 800 milligrams total for the day. And she had been fine on it, had also been taking oral contraceptives at that point. And then after a couple of years, she gives me a call one day and says, you know, for the last couple times of my period, I've been feeling really sick, and some nausea, vomiting, you know, feeling a little tremor, shakiness, all of these which can be side effects of a high lamotrigine level. So previously we had checked drug levels. Her dosing had actually given a quite normal drug level, right in the middle of where we would want it. But we rechecked it knowing that we had seen this association. So we had it checked during that period where she was not receiving hormonal supplementation. And suddenly her level had shot up very, very high. So we made a plan to keep her usual dose to give adequate seizure protection when she was taking the hormone pill. But then during that time of the withdrawal bleed and the no hormone, she decreased her dose a little bit and has been actually doing okay since. Depo can also do this as well. Moving on to our next form of birth control is the Depo Provera, so the injection shot. This is actually a synthetic progesterone. It's given by intramuscular injection. This has a risk over a long time of use to have a low bone density, so increasing risk for osteopenia, osteoporosis. And it's given more frequently for women with epilepsy. So usually it's given as an injection about every 12 weeks. Because of the way seizure medications and overall body metabolism can work, For women with epilepsy, it's actually given about every 10. So a little bit more frequent to make sure that there is adequate protection and use in family planning. And then finally, we have their intrauterine devices, or the IUD. So there's two main versions of this. There's one that can be containing the hormone progestin, and then there's the hormone-free version, copper. And here we see it's a small device. It's inserted into the uterus, and there it remains. It's effective with all seizure medications, and it's something that can be set and forget. So it can last up to 10 years. If plans change over that 10-year period, it can be removed, and then family planning and plans for children can continue. One of the common, I will say, syndromes, but impacts of sort of all these hormone changes over that 28-day period of a menstrual cycle is the emotional and physical symptoms that occur 7 to 10 days before a period. This is from a comic, Sarah Scribbles, who I actually like to read a lot. She sort of describes some of these symptoms over the way. I feel so depressed. What's wrong? Literally nothing. I don't get it, but I'm so sad. What's wrong with me? What could it be? And there her uterus is reminding her in a couple days, menses is probably on its way. Often these symptoms can improve once the period begins. So the diagnosis of premenstrual syndrome is made with a daily symptom rating scale. This checks for several different things, but can include some of the more emotional, so mood swings, depression, irritability, fatigue. I'll also throw in cravings there as well, or some of the more physical symptoms, so headaches, muscle, joint pains, breast tenderness. Mild premenstrual syndrome happens in about 75% of women. Wow, 75% of women, which is a pretty large proportion when you think about it. Moderate PMS can happen in 20 to 40% of women, and then severe happens in 2 to 5% of women. In terms of how this can relate to epilepsy, PMS is actually more common in epilepsy patients. And not only is it more common, but the most severe form can be more common than the general population. We don't know specifically why this occurs, but we suspect it could be likely multifactorial. So many different possibilities that can contribute to this increase. So what do we do about it? So balanced diet can be key, as well as limiting caffeine. So we have our image here of a lovely bowl of kale on a plate saying, I want to eat everything. Exercise. And sometimes medications can be helpful. So selective serotonin reuptake inhibitors, so SSRIs, these fall into the antidepressant class. And sometimes they can be given just around the time where PMS is most likely to happen. And sometimes it can be given every day. Next, we'll talk about another syndrome that has a specific interplay over time called polycystic ovarian syndrome. And what it is, it's a common hormonal disorder in women that causes enlarged ovaries and cysts. So here we have our uterus. We have the fallopian tubes on either side. The ovary here, this is a normal, an illustrated normal one, very smooth. And then here we see one is likely suffering from PCOS. So it's enlarged, has cysts. And we can take a look at this actually through an ultrasound as well. So over here we have normal ovaries. Everything here almost blends into the background. I'm not seeing a large amount of differentiation. Sizing looks appropriate. Whereas compared to over here, if we look at this tracing here, over to this tracing here, this one's much larger. We also see all these darker circles in here. And in ultrasound, that usually means fluid filled. And so these are all the cysts. So quite a few compared to not seeing any over here. And so when this is seen usually on ultrasound, or because of the symptoms we'll talk about, the diagnosis can be made. So what are those symptoms? Sometimes there can be menstrual irregularity, infertility, hirsutism, which means excess body hair, and or the opposite, balding or thinning hair, as well as obesity and acne. So not the best group of symptoms. The causes, again, there's that multifactorial word, but we can see it in terms of insulin resistance, so prediabetes, diabetes, raised levels of testosterone, obesity, or being overweight, and then particularly and most relevant for our women with epilepsy are medications, and specifically Depo. So in Depo users, it's up to 7 times more likely to have PCOS. And then also in temporal lobe epilepsy. Again, we think this might be from the hormonal imbalance, preventing ovarian follicles from maturing and forming into cysts. So what are we able to do for this? So sometimes the best ways to treat something that's multifactorial is to treat the different factors that might be applying. So remember that insulin resistance could contribute. So it can be treated with diabetes medications such as metformin. Healthy diet and exercise to help weight control. Spironolactone can be used. This counteracts and can reduce testosterone production. And then oral contraceptives to help regulate any hormonal imbalance. Sometimes, I'll also say, sometimes if it's believed to be the Depo or a seizure medication that's contributing, and it's a possibility, the medication can be changed. And then finally, menopause. So this is when the hormones estrogen and progesterone start to decrease over time. It's defined specifically as a full year without a menstrual cycle. And we often think of this as sort of at the end of a woman's life, but it actually accounts for 1/3 of a woman's life, which is a pretty decent proportion. And then here we have our cartoonist saying, instead of menopause, we're going to call it puberty part 2. So menopause is often preceded by perimenopause, and this can actually often last for years. During this time, there's a lot of changes in memory, sleep, sexuality, mood, and bone health. Estrogen and progesterone levels during this time begin to decline. But remember that both of these hormones can have influences on the brain cells, the neurons, with that excitation and inhibition again. And so by the nature of the hormones changing, the brain can also change. This can therefore relate to epilepsy. So with these changes, some women may respond differently. New onset seizures can actually occur, and it's difficult to say exactly what proportion this may happen in women, because also after the age of 60, strokes can be more common, and that can also be a leading cause of seizures. So it's always going to be difficult to tease out, is it actually the onset of menopause or another cause to lead to these new onset seizures? But nonetheless, menopause can definitely be a possibility. Some women may have improvement in their seizures. Again, if the hormones are starting to go away and they were playing a large role in the development of seizures, if they go away, seizures may get better. However, other women may actually have worsening of their seizures. Estrogen replacement is a little bit of a controversial topic in terms of how it relates to seizures. If estrogen itself can be a little bit excitatory, making seizures a little bit more likely to happen, is it always the best choice? And sometimes it can still be. And that's where the concept of individualized medicine has to come in. What are the risks and benefits of replacement or not replacing? And how does that apply to you as an individual? Which is the most acceptable, which is the most beneficial? And so it's often a pairing between you and your physicians to help make that decision. With menopause and epilepsy, not only was seizures changing at the time the hormones are changing, but seizures happening earlier in life can actually correlate with when menopause is most likely to happen. So with women who have no seizures throughout their life, the average age of menopause is about 51 years. For women who have frequent seizures, about 1 per month, that number drops by almost 4 to 5, down to an average age of 46.7. And we can actually see that it's been broken down over in this particular study, that very frequent seizures versus very rare seizures. In the rare seizures, so less than 20 in a lifetime, menopause actually starts to approach the control group around 50 years as opposed to 51. And so here's another one of my favorite cartoonists, C. Cassandra, and she is lamenting some of the PMS syndromes that she is likely to get on her first day of vacation. And so with that, I'll take any questions.
Thanks very much, Allison. So I think that Seamus is organizing the questions for us. There are several questions in the chat box, but Seamus, could you give us the next slide?
Yes, absolutely. I'm doing that now. Yeah.
Thank you. We appreciate the questions. So you can actually put the questions in at any time into the chat, and but feel free to start doing that now too. So as we're organizing that, I just wanted to also touch on another topic of hormone use in epilepsy and our transgender members. Doesn't look like the slide has completely loaded. There we go. The worldwide estimate is that there are 25 million transgender individuals ages 15 and older. And since there are approximately 50 million people with epilepsy worldwide, we can estimate that there are about 150,000 to 450,000 transgender persons with epilepsy worldwide. When using hormones in gender-affirming healthcare, both doctors and patients need to consider the effects of the seizure medications on hormone therapy as well as vice versa. And the slide also has another line that says, there we go. So as a physician, if I'm caring for a transgender person, I will consider using seizure medications that will not impact hormone levels. And it's very important to have work together as a team. And then next slide, please. I thought this is an interesting tidbit that a lot of people actually are unaware of, that there are many plant sources of hormones of both estrogen and progesterone. And estrogen is actually present in all of your soy lattes. So it's present in soy, flax, chickpeas, red clover, and many other plant products. And progesterone is a very common source of that is Mexican yams. I actually have a challenge remembering that yams are not sweet potatoes. Yams are actually white. Sometimes it's hard to know which is which. And Seamus, do you want to kick us off with the first question, or do you want me to read it?
Oh, I got it all set up. So we have some really great questions, everyone. So please, if you have any, definitely feel free to enter them in the chat box. But the first one we have is, if you had PCOS and hysterectomy leaving ovaries, can you still have symptoms and issues?
Yes, you can. So a lot of the hormones that get produced are produced from the ovaries. The uterus, which is what is removed in a hysterectomy, would not have sort of that same hormonal control. Additionally, even if the ovaries are removed, whether as a treatment for the PCOS or not, sometimes there can be some of the longer standing effects like insulin resistance that can continue to play a role.
Wonderful, thank you. And then we have another question. What happens with hormones and seizures if a total hysterectomy is performed, removing everything, including ovaries?
So that can, since the ovaries are included in that case, some of the hormone interplay, particularly catamenial epilepsy, can wind up acting in the same way as menopause can. It can sometimes be a little bit difficult to predict, as with menopause, but its potential seizures may get better. However, for some women, again, that hormone change or removal, seizures may get worse.
Okay, fantastic.
Yeah, and just a couple more words from me, mainly because we have plenty of time, is that catamenial seizures have been described for many years. Dr. Gowers described catamenial epilepsy in the 1880s, And as women, we can have catamenial anything. Some people will have catamenial migraines. Catamenial just means around menses. So of course, someone actually did try to do a total hysterectomy on women to see if seizures would stop. And this was done on many patients with epilepsy. And it didn't work. So it's unclear, probably a lot of reasons why it didn't work. So when women have a total hysterectomy, they are still able to make estrogen from fat cells. And in fact, that's one reason why it's thought that sometimes if women are a little heavier, they're less likely to get a lot of hot flashes and go through more severe menopausal symptoms, because we still make estrogen even postmenopausally. The issue is probably more the ratio, so the actual amount of estrogen and progesterone in the body, but what's probably most important, as Allison was showing on those slides with the graphs, is that it really is the ratio of estrogen to progesterone that's important. So during mid-cycle, when women have high estrogen and low progesterone, that's when they could potentially have an increase in seizures. And then right before bleeding, estrogen and progesterone both drop, and that of course can then lead to seizures. And then as she showed us with the cycles when women do not release an egg, and that happens in 10% of the general population and up to 35% of women who have temporal lobe epilepsy. So during that time, no progesterone is produced at all, so that estrogen is high. So then women will really kind of have scattered seizures through the second half of their menstrual cycle. So that's why it's complicated. And as Allison said, sometimes, tracking it more carefully with the seizure tracker is a good thing to do, because you can also track your menstrual cycles with that, and then you can graph it. And sometimes once you have a lot of information in there, a pattern will become more evident, especially if you graph it.
Perfect, thank you. And we do have a couple more questions that came in. One is, can you make specific birth control recommendations to patients based on their type of epilepsy, history of seizures, and type of medications, if this is not knowledge that OBGYNs would not have access to?
So yes, we can, and often as the epileptologist, the seizure doctor, I wind up doing just that. OBGYNs are fantastic at knowing the different medications and what the hormones might be over any during, what hormones might be released at any during time for that specific family planning means. But it's often winds up being a discussion between myself and that OBGYN, or both of us with the patient, to get a specific choice. One of the ones that I frequently will recommend, particularly to my younger women who are not ready yet to have children, if they choose to make that decision, is the IUD, because it doesn't have impact with the seizure medications. And it's something that, again, is good for several years. With low chance of failure.
Perfect, thank you very much. And we did have another question come in. Could you shed some light on pseudo seizure and whether there is any link of that kind of seizure with hormonal imbalance or missed menses?
Joyce, would you be willing to answer this one?
Let me, there we go. Absolutely. So, so probably not everyone in the conference is familiar with pseudo seizures. Neurologists, I guess, are complicated people that like to name things many names. So some of you may recognize instead non-epileptic seizure or psychogenic seizure, pseudo seizure. I kind of prefer the term non-epileptic seizure, but that seizure is when people have a behavior that looks like a clinical seizure, but when the brain waves are completely normal. So it is more related to mood disorders or stress, or kind of similar to post-traumatic stress disorder. So the question is shedding light on pseudoseizures and whether there's a link with hormonal imbalance or missed menses. It is a good question. So certainly people in general, when they have stress, that lowers the threshold for seizures, any type of seizure to occur, and including non-epileptic or functional pseudo seizures. And treatment for that is generally linked with seeing a therapist, a psychologist, practicing cognitive behavioral training to reduce that stress, but it wouldn't be linked particularly with the hormonal changes causing effects on the brain that actually affects epileptic seizures, not the non-epileptic seizures. Anything to add to that, Allison?
No, I think that was covered well.
Thank you.
Awesome. Thank you both. And we did have another question come in. What is the best vitamin to take, including what specifically that would benefit a woman with partial hysterectomy and seizures about one every couple months?
So anytime I'm asked about vitamins or supplements, things like that, the two that I will recommend pretty much for any woman, and then particularly women who may consider having children in the future, first is folic acid. It can help prevent fetal malformations, problems with pregnancy in terms of baby's health over time. I'll hold off on that full discussion because I believe that might be coming up a little bit later. And then for every woman, I always say vitamin D as well, just because that seems to be chronically low in every patient, particularly in women, and that can lead to long-term bone health, which with some medications, particularly phenytoin, valproate, things like that, can make bone health a struggle later on in life. And I'll ask if Joyce has any other recommendations.
No, thank you. It is a complicated question because I don't think there is one vitamin that's helpful to, all women. I guess, women, so we're going to hear in the later talk with Bethany Thomas about bone health and nutrition and vitamins, and it's going to target many things. So, a lot of people try different vitamins for bone health or for energy or for memory. And so of course it's a very big topic. So I don't know if you want to, I think that was Maria. I don't know if you want to clarify a little bit more. Is there a specific, condition you would like addressed? Because we certainly can answer that when we hear from Bethany Thomas. And I do see another question. I'll read it to save Seamus from getting back on. So there's a question about and this is for you, Allison, how is it determined if estrogen replacement is a good or viable option for women with epilepsy in menopause?
So it depends. It depends certainly on the individual woman. What's been the seizure history up until that point? Have seizures been incredibly well controlled? Okay, perhaps the risk of seizures or seizures worsening may be lower, and the estrogen replacement therapy might actually be a great option, particularly if there's a lot of symptoms of menopause for which the estrogen replacement might be able to help control. I could take an example of another woman who would ask the same question. Her seizures have been horribly controlled, frequent seizures, maybe a couple a week, more frequent than that. Yet, as menopause has been starting, hasn't been as severely affected by some of the side effects of that hormone withdrawal. Perhaps for that woman, the estrogen replacement, the risk of seizures or worsening of her seizures may be enough to say, let's hold off on that estrogen replacement therapy. We can revisit it later. Sometimes it's going to be borderline. We don't know the best answer one way or the other. And often at that point, I rather than give a specific recommendation or guidance to one of my patients, I say, what do you think is the best option for you? If we want to give it a try and we find out, nope, that's a bad idea, seizures definitely got worse, then we stop.
Perfect. Thank you very much. And we do have another question. Is it possible to treat hormonal imbalances with herbal supplements?
I'll let Joyce handle this one.
Thanks, Allison. So, it is possible. We talked about some of the plant sources of estrogen and progesterone. I will say that all of these need to be used with caution. So I do have patients who are very sensitive to estrogen in their diet. And in fact, they have found that in order to be seizure-free, they really do need to avoid all of the plant sources of estrogen, probably because of what Allison had talked about, that if you take estrogen, it increases excitation in the brain. And of course, the seizure is an electrical storm in the brain. Now, not everybody is affected that way, so it's not true for everyone, but there are supplements that can make life better, and but they all have to really be used with caution, and we'll hear more about that in Bethany Thomas's talk.
Perfect. Thank you, Joyce. And no more questions in the chat box as of now, but we do still have time. So if there are any other questions, please feel free to submit them.
And while we're waiting to see if there are more questions, I wasn't sure if we had time earlier, but I also wanted to call to mind when I had this slide about, famous people with epilepsy. Two people that I talk about in the office all the time now are Cameron Boyce and FloJo, Florence Griffith Joyner. So both of these people died from sudden unexpected death in epilepsy. And some of you, if you're younger on the call, may not be familiar with FloJo, but she was an Olympic athlete, track athlete, incredibly in incredible physical condition. Her claim to fame were her long fingernails that she always had when she was running. She had her first seizure and actually had a cavernous angioma in her brain. So she was at high risk for having a second seizure, but she opted to not start treatment. And unfortunately, with her second seizure, she died of sudden unexpected death in epilepsy. And there's a lot of information about SUDEP on the Epilepsy Foundation website. And Cameron Boyce is someone who I think many younger people are familiar with and older people not so much. He was an actor who had epilepsy. And I want to say in the spring of 2019, died from SUDEP, and his family has been trying to promote awareness of sudden unexpected death in epilepsy. And it was after his death and after actually seeing his family that I decided I would talk to everybody about that in the office to make sure that everybody was aware that SUDEP is the second leading cause of death in individuals with epilepsy. I see there are some more questions now in the chat. So I see one says, what can I do for frequent night sweats? Allison, do you want to take that?
Sure. So that's where, again, I would kind of revisit that discussion of, is hormone replacement therapy a viable option? Again, based on your prior seizure history, what other symptoms of menopause might you be having? How tolerable are those symptoms? If they're very disruptive to your life, then sure, bring that up and the possibility of estrogen replacement therapy with your physician.
Perfect. Thank you. And I just want to let everyone know we are going to take a 10-minute break, but so feel free to get a glass of water or take a break. Our next speaker will be at 10:15, but we do have a couple more questions, so we can absolutely answer those. One is, does being trans, female to male, and going on hormones raise or lower your chance of seizures?
So,
Allison, do you want me to take that? Or you
okay,
good?
Sure. Yeah, please go ahead.
Okay, so it can do both. It could raise or it could lower it. And so when you're transitioning and you're on replacement therapy, female to male, the goal would be to increase testosterone. Now you'll notice that we didn't really talk much about testosterone, and that's because the literature is really conflicted. There are some reports that say testosterone increases seizures. There are some reports that say testosterone decreases seizures, and the majority of the reports say that it has no effect on seizures. So it's unclear what would happen, and there's also less information about drug interactions. But I guess my gut is telling me that it is probably a little bit easier female to male than male to female for both those issues of interactions with your epilepsy medication and also changing the seizure threshold. You agree, Allison?
I agree. I'd also add that if there is excess testosterone and the ovaries do still remain, that can increase the risk of PCOS as well, too, since the extra testosterone is definitely a risk factor for it.
Yeah, very good point.
Great, thank you. And we did have another question come in. Can omega-3s also help with seizures along with a stress B complex vitamin along with your own multivitamin, only because some medicines can take away vitamins?
I'll ask Joyce to answer this one too, please.
Oh, sure. So, so once again, this is a challenging topic. Omega-3s, fatty acids, they're also blood thinners. And so there's no reason to be concerned about omega-3 fatty acids unless you reach over 3,000 units when you take it. If you're over 3,000, there is a chance of bleeding, especially if you also happen to be taking aspirin. But low dose is fine. There's not really much in the literature saying that omega-3 fatty acids would help reduce seizures. A stress B complex, lots of advantages for B complex, and I'm not sure you would necessarily need it if you were also taking a multivitamin. One thing that I was not aware of until just a couple of years ago was the fact that pyridoxine, which is vitamin B6, it's a water-soluble vitamin, but that one's very easy to actually become toxic with. And when levels are high, it can cause numbness and tingling. And I must say, I've been diagnosing pyridoxine toxicity in a lot of patients who are taking a multivitamin plus a stress B complex. And it doesn't really take much to get high levels of pyridoxine. These things can also be measured. When you have your blood drawn, you can ask your physician, hey, could you check my thiamine level or my folic acid level or pyridoxine level or vitamin B12 level? So you can do this with a little more knowledge so that you'll know if you need higher levels of certain things.
Perfect, thank you. And looks like we do have time for one more question. So this person asked, I had a seizure a few years back, but was not diagnosed with epilepsy. Since there was no family background or no reoccurrence of seizures, I had sleep problems. And the next morning, while I had only slept for 1 hour without any sleep last night, is when I had the seizure. The neurologist advised not to miss on sleep in the future. The EEG showed epileptic form activity. What could be the reason? Missing sleep really does have such a huge consequence.
So missing sleep does can have a major consequence. There are certain things that can decrease the seizure threshold, meaning make seizures more likely to happen. Decreased sleep is definitely one of them. Things like infection can as well. Some medications can as well too. Oftentimes the diagnosis of epilepsy versus just one seizure can be made with essentially a toolkit, several different things like whether it's imaging or an EEG, history of prior seizures, and all those together can help a physician assess the risk of a repeat seizure. And so that all those things often are taken in conjunction when I make an epilepsy diagnosis, or say, had one seizure, these are the risks that can make a seizure more likely to happen, and not make that epilepsy diagnosis. Joyce, do you have anything to add?
Well, I apologize. I was a little distracted for a second, but so I apologize if you've already said this. I'm old, so I know how things used to be in the past. In the past, we used to say people who had just a single seizure did not have epilepsy. However, in your situation, since you had a seizure and your EEG shows epileptiform abnormalities, that actually means you have epilepsy. So that definition changed a few years ago. So you didn't just have a single seizure, you have epilepsy. Now, I guess I find it unusual for sleep deprivation to cause epileptiform abnormalities unless you're really, really sleep deprived. So I am very concerned about your risk of future seizures, and you might want to speak to your doctor about doing a long-term EEG, like a 48-hour, 72-hour EEG. And then also, I pay a lot of attention when people have epileptiform abnormalities about the duration. And I'm not sure if your doctor meant you had generalized spike and wave, which that could be genetic. And it's possible to have a genetic family history of epilepsy. And actually, you might not be aware because Aunt Mary may have just had staring seizures when she was a kid, and then she grew out of it, but she actually had epilepsy that was never diagnosed. So it's probably important to get a little bit more information, both from your family, but as well from the doctor about, did you have generalized spike and wave? Could it be genetic? And if you had generalized spike and wave, how long were the discharges? Kiffin Penry did work in the 1990s, a lot of work on people with generalized epilepsy, and taught us that if these spike wave discharges last for more than 3 seconds, we should worry about that. And so it might be good for you to ask your neurologist, how long were these epileptiform discharges that I had? It can be helpful, but you might need a little bit more input from your doctor.
Perfect. Thank you very much, everyone. Phenomenal questions. So it looks like with staying on schedule, our next speaker will be up in just a minute. So we're gonna start moving ahead at 10:15 with our next speaker. So it is now 10:15. So I'm gonna hand it over to Joyce at this time.
Great, thank you very much. Thank you very much, Allison. That was really a great job. We really appreciate it. And thank you very much for answering all those questions as well. So it is my pleasure now to introduce Dr. Julie Tsao. She's an assistant professor in clinical neurology at the Lewis Katz School of Medicine at Temple University. She's also the associate program director of the neurology residency at Temple University. Very important job, training our future doctors. She graduated from the Medical College of Georgia in Augusta, Georgia. She completed her neurology residency at New York Presbyterian Hospital and New York Presbyterian Hospital Weill Cornell in New York City. She returned to Georgia for her fellowship training in clinical neurophysiology epilepsy tract at Emory University in Atlanta, Georgia. After spending a few years in private practice, she returned to academic medicine at Temple University, where we're very happy to have her here in Philadelphia. She completed research on status epilepticus and has a clinical interest in women's health and epilepsy. And her topic today is planning a pregnancy. Thank you very much.
Okay, thank you so much for the kind introduction. So today I'm excited to be talking about planning for pregnancy in women with epilepsy. We're going to be covering a couple of different topics. First, we're going to review the epidemiology associated with women with epilepsy as well as pregnancy, the impact of pregnancy on seizure control, and also the impact of seizures and the medications we use to treat seizures on the pregnancy and the outcome of babies, and also different ways to improve the outcome of pregnancy and the baby's health. And also, we're going to be ending with some recommendations regarding breastfeeding and general safety precautions. First, we want to make sure that everyone is aware that you are not alone in this. More than 1 million women with epilepsy are in the childbearing years, meaning that they're between the years of puberty and before reaching menopause. About 24,000 babies are born in the United States are born to women with epilepsy every year. And that equates to about 1 in 200 pregnancies where women with epilepsy are having babies. And fertility doesn't seem to be negatively impacted by epilepsy. So first, we're going to be talking about how seizures are impacted by the pregnancy, and is there any change to seizure control during pregnancy? In general, pre-pregnancy seizure control usually determines the seizure control during pregnancy. And most women, about 60%, will have no changes in seizure control. About 15% will have less frequent seizures during pregnancy, and about 23% will have more frequent seizures during pregnancy. And some women who have catamenial epilepsy may be in the group that has less frequent seizures during pregnancy because of the absence of the cyclical hormonal changes and the increase in general progesterone levels during pregnancy. And knowing that a quarter of women may experience more frequent seizures during pregnancy, what are some reasons for the increase? Some women during pregnancy may actually choose to lower their medication doses or stop taking them altogether because they're worried about negative impact of the medications on their babies. And some hormonal changes throughout pregnancy, where some weeks of pregnancy may have higher estrogen to progesterone ratios, may increase the risk of seizures. And overall, during pregnancy, sleep deprivation and stress may also pose a risk. And medication levels may also drop during pregnancy. And why is it that some of these medication levels drop? Much of it is due to metabolic changes that occur during pregnancy, such as weight gain, as well as increased breakdown of medications during pregnancy by the liver, and also increased elimination of medications by the kidneys. And during pregnancy, the medications may not be absorbed as well for the body to use. And are all medications affected? Not so much. Of the studied medications, the levels of certain medications like Lamictal, Keppra, Triloptal, and Zonegran tend to drop the most. And it's important to figure out what the baseline medication level was that controlled seizures before pregnancy, so that throughout pregnancy, knowing that some medication levels may drop, we can check medication levels monthly and try and aim for that goal level that we know controlled and helped seizure control. And in terms of blood work during pregnancy, we would recommend checking the medication levels at the same time of the day and from the same lab and before you take the medication, so that we can try and keep as many things consistent as possible, because of course there can be variabilities from lab to lab. And the medication doses based on the levels may need to be increased incrementally throughout the pregnancy to try and control the seizures. And so by the end of the pregnancy, the doses may be much higher than what you started the pregnancy with. However, the goal is to aim for the level, and higher doses don't necessarily mean that your body's exposed to that much more medication, because your body's working that much harder to try and get rid of it during pregnancy. And of course, getting medication levels checked and changing the doses every month is going to be a lot of work. And so is this really helpful to increase medications and to check levels? Are seizures or trying to prevent seizures really worth it? And do seizures really pose a risk of harm to the babies? And we have some information on this in that seizures during pregnancy do increase the risk of pregnancy complications, such as preterm delivery, as well as preeclampsia and ruptured placenta, as well as hyperemesis gravidarum and increased risk of bleeding during pregnancy, during delivery. And these complications can be twice as much as the healthy population. The only thing is that there's no need for elective C-section just because there is a diagnosis of epilepsy, unless there is a history of some kind of a vascular or blood vessel malformation in the brain where pushing during vaginal delivery is going to be not recommended. And seizures during pregnancy also increase the risk for babies in that it increases the risk of having low birth weight and small for gestational age babies. And there's also increased risk of babies who may need educational support or have lower verbal IQs if they've been exposed to multiple tonic-clonic seizures during pregnancy. Now that we've established that seizures are in fact harmful to moms and babies during pregnancy, are there different things that we can try and do to, are these risks, what are the risks associated with trying to control these seizures? Are there risks associated with the medications that we may want to use? So let's first talk about the rate of birth defects in the general population. For one, no woman is guaranteed to have a healthy baby, and in the general healthy population, the rate of birth defects is about 2.2%. And in women with epilepsy taking medications, the rate is about 4 to 6%. But it's individual for each medication. And this means that more than 90% of women with epilepsy will have healthy babies. And knowing that some medications seem to increase the risk of birth defects from 2.2% to up to 4 to 6%. Is there anything that we can do about medication dosing to try and minimize the risk? Some general medication guidelines to try and minimize the risk that the medications will increase the risk of causing birth defects is that one medication is in general safer than taking multiple medications. And in general, lower doses that control seizures are better than taking very high doses. And certain medications are safer than others, and of course, certain medications have been studied far more than others. But we would encourage you to work with your doctor to get your seizures under good control and on a medication regimen that works best for you before you get pregnant. Because basically, if you're exposing your baby to medications during pregnancy, let's aim for a dose and a medication that actually controls the seizures so that you're not exposing the baby to the medication and also multiple seizures. And besides medications, are there other factors that can increase the risk of the baby having birth defects? And one of the major ones is having a family history of birth defects. And having a previous history of a pregnancy with multiple birth defects can increase the current pregnancy's risk of having another birth defect if the mom is on the same medication. And now we've talked about different birth defects, but what are these birth defects that we're referring to? And I'm just going to check and make sure that I'm sharing my screen actually.
Yes, we can see it. We're good.
Okay, thank you.
Where it says intrinsic factors?
Yes, okay,
Yes.
Perfect. All right. So what are these birth defects? These are abnormalities that are present from birth. And just noting that some cardiac birth defects may actually not be noticeable or clinically apparent until the baby is well over age of 2. But the more common birth defects that we encounter are cleft lip and cleft palate, as well as the heart defects, cardiac defects, and urogenital defects like kidney problems and reproductive, involving the reproductive system as well. And neurotube defects, which we're going to be talking about in more detail because this will have implications on the baby's neurological development and cognitive health. Neurotube defects are structures that eventually forms the brain and the spinal cord. It first starts out as a flat structure that then slowly folds and closes like a zipper to form a long tube. And not closing fully can lead to spina bifida or brain defects, depending on the level, depending on the location of the opening. And lower in the spinal cord, the opening may cause spina bifida that can lead to weakness or numbness in the legs, and not closing higher up can cause structural problems with the brain development. It typically closes within the first month of pregnancy, which is often before the woman realizes that she is pregnant. And so this can be commonly seen in the general population as well. And the rate of neurotube defects in the healthy population is about 1 in 1,000 pregnancies every year. But certain medications like Depo and Tegretol actually increase the risk of the neurotube defects. And Depo can actually increase the rate to about 1 to 2% per pregnancy, which means that there's a 1 in 100 or 2 in 100 chance of having a baby with a neurotube defect. But what can we do to try and decrease the risk? And it seems that folic acid decreases the rate of neurotube defects in the healthy population. And we typically use this information to help our patients with women with epilepsy as well. And we'll come back to the folic acid talk in a little bit as well and go into more detail. Now we're going to talk about some information that has been gathered from different registries, which are specific to every country and region, and also some observational studies that have been done to comment on the neurodevelopmental status of the babies and their cognitive health outcomes. This information is from the North American Anti-Epileptic Drug Pregnancy Registry, and this information gets updated periodically, and this is updated as of October of 2020. And this is a registry, meaning that volunteers of pregnant women taking one of the studied drugs will provide information about their pregnancies and their health, as well as the health of their babies once the babies are born. And from this information, we've gathered a lot of information regarding the risk of birth defects associated with different medications. And here on the left-hand column, you'll see that the names of the seizure medications, and the N means the number of women taking this medication, and the percentage means the rate of birth defects associated with this particular medication. And we can see that from the North American registry, the most commonly used medication during pregnancy for seizures is lamotrigine or Lamictal, at about almost 2,500 women taking it. And the rate is relatively low at 1.9% of birth defects. And the second most commonly used medication in this registry was the Keppra or the levetiracetam. And again, out of over 1,200 women taking this medication, about 1.8% of women had babies who had birth defects. So these numbers are relatively low, but let's look at some outliers. We can see that this bar graph is much higher than the other medication rates, and this is valproate or Depakote. And this seems to have, out of this registry, the highest rate of birth defects at almost 9%. And the next highest is the phenobarbital at about 5.5%. And Topamax is at 4.4%. And a lot of this information came out after 2010 when it was discovered that a lot of babies whose moms took Topamax had cleft lip and cleft palate birth defects. So the rates of use of Topamax have been decreasing in the more recent years, but there's still a high number compared to other medications in this registry. And you'll notice that down here, some of these birth defect rates are at 0%, which looks very favorable. But at the same time, we have to keep in mind that for this particular medication, lacosamide or Vimpat, only 65 women on this registry of a couple of 100,000 women were taking the medication. And so we have to take this rate with a grain of salt and wait for some more studies to be done on that before we take this as real. And in general, some birth defects and medication associations of the medications that have been studied enough. For one, low birth weight babies are typically associated with moms who took Tegretol or Depakote or Topamax. And small head size is also often associated with Tegretol, Depakote, and Dilantin. Heart defects are more often associated with Depakote and phenobarbital, whereas the cleft lip and palate is associated with Topamax, as we just discussed, and also Depakote, phenobarbital, and Lamictal. And we just saw that the rates of Lamictal and birth defects is relatively low, but at the same time, when the birth defect is present, it seems that they're more often associated with cleft lip and palate disorders. And spina bifida, as we mentioned before, is highly associated with Depakote and Tegretol more so than the other seizure medications, with rates that can range up to 1% to 2%. So in addition to these structural abnormalities that can happen and be associated with certain medications, are the babies at risk of neurocognitive problems? And this information was gathered from this study called the NEED study, or the Neurodevelopmental Effects of Anti-Epileptic Drugs study. This is a study that ran for many years over many centers and studied 4 particular medications. And these women were taking one of these medications in monotherapy. And the studied medications were Tegretol, Lamictal, Dilantin, and Depakote. And the rates of the cognitive status of the babies were compared amongst these 4 medications. And those babies were tested for their cognitive status at different intervals up until the age of 6. And based on this study, we found some really interesting information, which is that a lot of different factors play a role in the baby's IQ or the cognitive status. And first and foremost, the mom's IQ seems highly correlated with the baby's IQ. And the mom's age also plays a role. The gestational age of the baby, meaning that the longer the baby is in the womb, the better the chance the baby will have a normal IQ or high IQ. The mom's use of folate seems to help improve the baby's IQ, and the socioeconomic status, as well as the lack of tobacco use and alcohol use, plays a role in the baby's IQ. And in addition to all of those factors, it seems that Depakote exposure in utero seems to lower the baby's IQ, where the baby's IQ doesn't correlate with the mom's, versus exposure to these other medications, the Tegretol, Lamictal, and Dilantin, did not negatively impact the baby's IQ. So besides the structural and the cognitive risks associated with different anti-seizure medications, is there any associated risk of neurobehavioral changes with medications? And of course, more studies are needed to make more comments on this, but some studies suggest that Depakote, more so than other medications, is associated with increased risk of autism spectrum disorders and also ADHD. So besides structural, behavioral, and cognitive impacts of anti-seizure medications, are the children born to parents who have epilepsy also at higher risk of themselves developing epilepsy? And that really depends on the type of epilepsy and who has epilepsy. There is a higher risk of passing on generalized epilepsies than focal epilepsies. And moms with epilepsy tend to pass it on at a slightly higher rate than dads who have epilepsy. And if the mom or the dad has epilepsy, the risk of their child having epilepsy is about 5 to 10%, compared to the general population where the risk of epilepsy is about 1 to 2%. So it may be worthwhile to talk to a genetics counselor about weighing these risks. So now we've talked about the different impact of pregnancy on seizures and seizures on pregnancy, and also medication effects on the babies. But are there things that we can do to try and improve the outcome for the mom and the baby? And remember that you're already doing a lot during pregnancy by not smoking or drinking, exercising, eating healthy, and sleeping. They're all helping the baby develop well. And we would encourage you to work with your doctor to get the seizures under control by checking levels regularly and working on adjusting the doses in a timely manner. And be sure to report all of the seizures to the doctor, because maybe treatment needs to be adjusted sooner than the 1 month mark from your last medication change, or maybe the level needs to be repeated to see what's going on. And for some women who've already had some kind of a epilepsy surgery with a neuromodulation device like VNS or RNS, it seems like the preliminary information shows that these modulation devices, while acting like a seizure medication, do not seem to cause birth defects like the medications that we take. So it seems like it's a bonus. And folic acid supplementation, which seems to help with reducing the risk of birth defects. And we've talked about folic acid supplementation in regards to the neurotube defects and also the baby's cognition. So let's talk about this a little bit more in detail. So folic acid, or folate rather, is a B9 vitamin, and it's found in some foods naturally, mostly in leafy green vegetables, as well as citrus fruits and seeds and nuts. And it's needed for the body to make new cells and generate new tissue at the cellular level. And it's vital for the development of the new neurotube. And you've heard me kind of using these interchangeably, but is there really a difference between folate and folic acid? And the answer is actually yes. Folate is the naturally occurring substance that's found in foods, and it's ready for the body to use. However, folic acid is the man-made and synthetic compound that's used in supplements like vitamins and also in fortified foods like cereals and breads that are fortified with folic acid. The main reason to notice that there is a difference, to understand that there is a difference, is that some people with a specific gene mutation called the anti-HFR gene mutation may have difficulty processing the folic acid into a usable form for the body. And it may be worthwhile to talk with your doctor to decide if there is any further testing or any further considerations to take in regards to folic acid supplementation to decide if maybe you need a different form of folic acid that's actually easier for the body to use if you're missing this gene. However, in the studies, the form that's been studied for decreasing the rate of neurotubes is the folic acid form. Overall, in regards to folic acid, we would recommend supplementing with it because studies have shown that supplementing with folic acid seems to decrease, seems to improve the neurodevelopmental outcomes of the babies, as well as decreasing the rates of autism and improving the cognitive health of the babies. However, some studies also show that very high doses at more than 5 milligrams a day can actually lead to low birth weight babies and also increase the risk of autism. So it's a fine balance of trying to weigh the risks and benefits, but usually the goal dose for most pregnant women is somewhere between 0.4 milligrams to 4 milligrams. And talk with your doctor about what dose is optimal for you, because some women who have had babies with neurotube defects in the past may actually need to be on that higher end of the recommendation. And ideally, this really should be started before you're planning pregnancy because almost half of pregnancies are unplanned. So you want to make sure that you have enough in your system during that first month of pregnancy when the vital neurotube is being formed. And what can you do during labor and postpartum period to reduce your rate of seizures? Because the peripartum period seems to be a period where there's heightened risk of seizures. And it's very important that you don't forget to take your medications during labor because labors can last many hours and you want to make sure that you're not missing your dose that's due at that time. And also talk with your doctor beforehand about having a plan on how to reduce your medication once you've delivered the baby. Because some medications like Lamictal, if not reduced quickly enough, may actually cause many toxic side effects like dizziness and blurry vision and imbalance. And some medications that were increased can be more gradually reduced over a couple of weeks. And be sure to have a sleep schedule or a plan for how you're going to maintain your sleep once the baby is born, because you want to make sure that you're not too sleep deprived and increasing your risk of having seizures. And it may be helpful to have a partner or a family member help you with an overnight feed so that you can try and achieve consecutive hours of sleep. Now that you have delivered the baby, what about breastfeeding? Is it safe and helpful for the baby? There are a lot of benefits of breastfeeding for the baby, ranging from respiratory tract infections to decreasing the risk of eczema and asthma, and decreasing the rate of obesity and diabetes and childhood leukemia, and also sudden infant death syndrome. So there are many benefits to the baby, and there are also many benefits for the mom, as breastfeeding has shown to decrease the rate of breast cancer and also ovarian cancer. And it also seems to decrease the rate of postpartum depression and diabetes. but will the medications be transmitted to the babies, and is that going to be harmful for the babies? So it is good to keep in mind that yes, all seizure medications can be present in the breast milk to some degree. However, it's still usually less than what was being delivered to the baby via the placenta when the baby was in the womb. And when they've done studies of the breast milk and studied the level of the medication compared to the mom's blood level, they've shown that some medications like Depo only is present in about 1 to 10% in the breast milk compared to the blood, whereas some medications like Keppra and gabapentin or Zuckerman are present in up to 130%. So more is present in the breast milk than in the mom's blood, which is very interesting. And this was really variable, mainly dependent on the properties of the medications themselves, where smaller medications, smaller molecules that are not really bound to other things like protein that increase the size of it, and molecules that actually like to be in a high fat content will have an easier time going into the breast milk than some of the other medications. And from a recent study from the MONID, which is the Maternal Outcomes and Neurodevelopmental Effects of Anti-Epileptic Drug Study, they measured the levels of 7 different medications, the Lamictal, Keppra, Tegretol, Trilactol, Depo, Topamax, and Zonegran in breastfed babies, as well as the moms, to compare, okay, if this amount of medication is present in the moms, then what's the amount present in the babies? And is that going to be too much or toxic for the baby? And what they found is that the levels of these 4 medications, Tegretol, Trilactol, Depo, and Topamax, are really very low. And it's kind of below what they set as the range. So levels of Keppra and Lamictal were present, but when they looked at the level of the baby compared to the mom's level, the Keppra level was only about 5% of what was present in the mom's blood, which is quite low, versus Lamictal, which seemed to be present in almost be as high as almost 30% of what was present in mom's level. And the level of the medications in the baby's body is really going to be dependent on the baby's ability to absorb the medication, as well as metabolize and work with it, and also how efficiently it clears the medication. And in general, premature babies are going to have a little bit of a harder time getting rid of that medication than full-term babies. And it's interesting that even though Keppra was highly present in breast milk, the fact that only a little bit of it comparatively is present in the blood is interesting. And that may be because Keppra is mostly cleared through the kidneys. And babies in general have a bigger kidney compared to their body size than adults, so they're very efficient in clearing out the Keppra from their blood, from their body, whereas Lamictal actually requires some kind of an enzyme from the liver to process the medication. And that process may not mature in the babies until about age 2, which may explain why there's more Lamictal that's measurable in the baby than what's expected based on the transmission rates of the breast milk. In general, breastfeeding is actually encouraged, despite knowing all of this. It's encouraged by the American Academy of Neurology that women with epilepsy breastfeed their babies. The main thing to do is to monitor the baby for any kind of side effects that's concerning, such as somnolence and sleepiness, but also poor appetite and not eating. And if there's any concern for side effects with the babies, we can certainly check levels in the baby and just make sure that not too much medication is causing harm. And if you are breastfeeding, try and take the medication right after you breastfeed so that the medication can stabilize and hopefully be a little bit lower by the time you're due for the next feeding. And multiple studies suggest that even the breastfed babies, even if they're exposed to anti-seizure medications, still had higher IQs and better verbal abilities at 6 years than babies who are not breastfed. And finally, some general safety recommendations. Be sure to take your medications after delivering your baby because, of course, things are going to be hectic and you're going to be sleep deprived and there's going to be a lot to keep track of. But be sure to take your medications and try and develop a sleep plan and have somebody with you when you're bathing the baby, just in case a seizure happens. Somebody's there to make sure that the baby is, doesn't fall into the water. And make sure you change the diapers on the floor so that, again, in case something happens, the baby's not up on the changing table by himself. And try to avoid front and back carriers. In case a seizure happens, you don't want to fall and injure the baby. So finally, some key points. Again, more than 90% of women with epilepsy on medications will deliver healthy babies. So that's always something to keep in mind, even though there's a lot of scary information out there. And some anti-seizure medications do increase the risk of birth defects, but the risk associated with the anti-seizure medications can also be dose dependent. And so work with your doctor to get you on a regimen that works for you before you become pregnant so that we can minimize the risk of seizures during pregnancy. And many seizure levels do drop during pregnancy, which can increase the risk of seizures. So again, work with your doctor to develop a plan to monitor your levels so that we can increase the dose and try and prevent seizures from occurring. And develop your a plan on how to lower the medications back to the pre-pregnancy level after delivery so that we can minimize the risk of toxic side effects. And please do supplement with folic acid to decrease the risk of birth defects and to help the baby's brains develop. And breastfeeding does expose the baby to anti-seizure medications, but it still seems to be beneficial for the baby's development and is encouraged. And be sure to follow up with your high-risk OB as well as your epilepsy specialist and genetics counselor. And please do register with a pregnancy registry because, of course, we don't do experiments with pregnant women. So a lot of the information that we have gathered is from passively from registries and observational studies. So these are some sources to check out so that we can continue to gather some more information for everyone who this may be helpful for. Thank you.
Thanks very much. So I know that people are hopefully using the chat to type in some questions for us. While we are waiting for questions, I just thought I would touch again about autism and seizure medication use. So overall, there's a 4-time increased risk for autism and autism spectrum disorder in children of women with epilepsy compared to the rates in the healthy population. So it's 6% for women with epilepsy, generally thought to be 1.5% for the healthy population. The highest risk certainly seems to be in children that are exposed to Depo in utero. But one thing we do have to keep in mind is that risk is very dependent on the dose. And that's true for all of our anti-seizure medications. So we do know that being on 2 medications is a higher risk than being on 1. And also that being on a higher dose of medication it is an added burden compared to a lower dose. And in fact, if you look at the data very carefully about birth defects and epilepsy, you see something very surprising. And that is, that doses of Depo less than 500 milligrams are actually considered very safe. The risk of having a child with autism or a birth defect on that dose is quite low. Now, of course, for the women that are on this call who have epilepsy and are taking Depakote, probably very few are only taking 500 milligrams a day. But the point is also that if you've been seizure-free on Depakote and the other medications do not control your seizures, so you and your doctor have decided as a team that you'll be staying on Depakote, it's also important for you and your doctor to review the dose of your medication. And if you're able to reduce the dose, say from 1,500 milligrams a day to 1,000 milligrams a day, that actually is going to be much safer. And so all kinds of things to think about as you're planning your pregnancies.
Perfect. Thank you very much, Joyce. And it looks like we did have some questions that came in. The first one is, does having epilepsy as a pregnant woman automatically qualify someone as a high risk?
In general, I do recommend that my patients who have epilepsy see a high-risk OB, just because there is a heightened risk of pregnancy complications. So I do generally recommend that.
Perfect. Thank you very much. Another question is, should nursing be timed in any way when you take your medicine?
So usually, I mean, obviously the baby's going to be feeding more frequently than the usual dosing of anti-seizure medications. But I would recommend taking the dose that's due right after feeding if possible, so that by the next time the baby needs to be fed, the dose has kind of decreased, or the level has kind of decreased as much as possible. But I wouldn't hold the medication dose while you're nursing. I would just try and take it right after.
Okay, perfect. Thank you. Another question that came in is it better to be on low doses of 2 medications or on a higher dose of 1?
So this is a great question, because, you know, we have talked about one medication is better than 2 medications, and lower doses are better than multiple higher doses. But it's really a regimen that, you know, works best for you. Definitely the studies have shown that polytherapy, taking more than 1 medication, does increase the risk of malformations. However, for some medications, higher doses are also associated with a higher risk. So it's really weighing the risks and benefits, but ultimately trying to kind of figure out what regimen works for you to control the seizures. I don't know if you have anything more to add, Joyce.
Well, I guess the only thing I would have to, I agree with what you said. The only thing I would have to add is that it may be more challenging to be on 2 medications, because you may be chasing levels through the whole pregnancy. So, so for those women that are on this and have successfully gone through a pregnancy on a medication like Lamictal or Keppra, they know that their levels change all the time. And so my patients, as they're getting blood work checked, I'm always saying, oh, level's too low. Oh, level, you know, it's very rare for the level to be too high. But actually somebody I think might be on the call who we were able to lower her Depakote dose just in her, just recently during her pregnancy. And so it may be very challenging for you and also challenging for your doctor. So, and actually, as I'm speaking, it reminds me of something that's very important too, and that is that all women should know what their goal levels should be during their pregnancy, because once you're pregnant, we're not really thinking about the dose as much as we're thinking about the level. So let's say that you are on Lamictal and your level runs between 4 and 6, and that's the goal during pregnancy. And, you know, so let's say you're taking Lamictal and it's 400 milligrams, gives you that 4 to 6 level. During pregnancy, if your level drops down to say 2, you would be at risk for having seizures, and your doctor would increase your Lamictal dose. So if you're then on 600 milligrams, your baby is only exposed to the level in your blood. So they'd still be exposed to that same goal of 4 to 6. I hope that makes sense. So I know that just my general practice, if I have a woman who is on low doses of 2 medications, that I will try to get them onto monotherapy, just 1 drug, even if I need to go to a higher amount to keep them seizure free.
Yeah, wonderful. Thank you very much. We did have another question pop in the chat box, and it is it safe to take Keppra and lamotrigine while you are pregnant? Would it affect the baby?
So in general, Keppra and lamotrigine are 2 of the safer choices in terms of anti-seizure medications during pregnancy. They typically, in multiple different registries, they typically have the lowest rates of birth defects associated with them. So they would be the preferred medication choices for young women of childbearing age.
But I would just add at the same time, if you could be seizure free on just Keppra or seizure free on just lamotrigine, that would be better than being on two medications. The other thing that's also very, I think, reassuring for many women when they're pregnant is to also have, ultrasounds done, so that usually the defect that is noted in people taking lamotrigine far and away is cleft lip and cleft palate, and that can be diagnosed before your child is born. And of course, that can be surgically corrected. And knowing in advance can prepare you for that outcome as well. So that can be extremely helpful. And but once again, 1 drug, as a general rule, 1 drug is better than 2 drugs, no matter what the drug is.
Okay, great. Thank you. No other questions in the chat box right now, but we still do have plenty of time for questions. So please, if anyone has any questions, feel free to use the chat box.
I guess while we're waiting and as we're getting very close to break, I'd just like to thank Dr. Tsao for her wonderful talk. That was terrific. I would really appreciated you taking the time to prepare and give the talk today. Really appreciate it. Thank you.
Thank you so much for the invitation.
Yes, thank you, Dr. Tsao. We really appreciate it. Looks like we did have a question pop in, and it is, do you have statistics on the increased risk of bleeding for women with epilepsy who give birth with or without seizure medication?
Joyce, I don't know if you have an answer for that.
Yeah, sure. So this was a very common concern. Actually, when we first started doing this conference, we used to have a talk about how women during labor on particular medications needed to have supplements with vitamin K to reduce not just their risk of bleeding, but their child's risk of bleeding. So it turns out that there is a 2-fold increased risk of bleeding in babies that are exposed in utero to medications like phenobarbital. Phenobarbital is a medication that is not very popular anymore, and most women are not taking it through a pregnancy. But there was a concern that the phenobarbital, and there was a slight concern for Dilantin and Tegretol, that it may interrupt clotting factors, and so that there was a higher risk for bleeding. There were reports of babies bleeding into kidneys, brain, and skin, and that was preventable with vitamin K. However, if you give women who are pregnant vitamin K, you are increasing their risk of having blood clots. And of course, we know a lot about blood clots now as we're hearing about blood clots with vaccines. We used to routinely supplement with vitamin K if women were on liver-inducing anti-seizure medications. That's no longer done, with the exception of phenobarbital. So for women, and I actually would probably have to review this again because it's been a long time since I followed a pregnant woman on phenobarb. But last time I looked, it was the only medication that required some vitamin K supplement in labor to reduce that twofold increased risk of bleeding. And that's a twofold increased risk of a very low number.
Perfect. Thank you. And just to let everyone know, we are entering our break and our next speaker will be at 11:15. But we do still have some time if people have questions. And it looks like one did pop up. Would seizures keep me from getting pregnant, especially after the age of 30?
So not so much. So they have taken a look at the fertility rates of women with epilepsy and women without epilepsy. And it seems that the time to getting pregnant is pretty similar in both groups. So women with epilepsy do not seem to have a lower rate of getting pregnant or lower chances of getting pregnant. Although the overall rates of getting pregnant after the age of 30 does decrease as we get older. And Joyce, I don't know if you have any more to add.
Yeah, no, it's it's a burden for all women, right? We spend so much time trying not to get pregnant, and then sometimes there are fertility issues. But no, the fertility seems like it's about the same as the general healthy population. The issue over 30 is really age more so than anything else. And 30 is extremely young. I saw another question, Seamus. Shall I just read it?
Yeah, absolutely. It looks like it was a statement.
Okay. I saw with cleft lip or palate can be inherited, but can that mean that either the person or child can develop seizures? So I think what they're asking is, if you have a child who has cleft lip or cleft palate that is running in the family, would that increase the risk of that child having a seizure? The answer is no. Cleft lip or cleft palate is not a risk factor for developing epilepsy.
Perfect. Yeah. Thank you, Joyce, for that pickup. Everyone, again, just our next speaker will be at 11:15. So you have time for a quick break.
Great. Thank you.
Welcome back, everyone. I'm now going to hand it over to Joyce to introduce our next speaker.
Great, thanks very much, Seamus. So it is my pleasure to introduce Dr. Bethany Thomas. She is an epilepsy nurse practitioner at the Penn Epilepsy Center. I'm with her every Wednesday here at the Penn Medicine Radnor. It's lovely to have her here. She received her bachelor's in science of nursing, master's in science of nursing, and doctorate in nursing practice from Thomas Jefferson University. She holds certification in neuroscience nursing and worked as a nurse in the neuro step-down unit and the epilepsy monitoring unit for 5 years before transitioning to her current role. Her clinical interests include pregnancy and epilepsy, adolescent transitions to adult care, and improving the use of nurse practitioners and physician assistants in neurology care settings. And her topic today is bone health, nutrition, and vitamins. Welcome.
Thank you. Thank you, everybody, for spending this beautiful Saturday morning with us. I'm excited to be with you, and we'll pull up my slides and get started. So today I'm here to talk about a large topic, one that usually draws a lot of questions, so feel free to enter those in as they come up. We'll have plenty of time for questions and answers at the end, but I am here to talk about nutrition, vitamins, and bone health as it pertains to epilepsy. So again, a pretty wide topic. We'll go over some implications for diet and nutrition as it pertains to epilepsy and overall health, vitamins and minerals, herbal supplements, and then finish up with bone health. So I thought it would be fitting to start with reviewing the history of where diet was started to be considered as an epilepsy treatment. So this is certainly not a new idea. Hippocrates, who is the father of medicine, mentioned fasting as a treatment during his time. And this was also referenced in the Bible. So there's a Bible passage noting that fasting was recognized as a potential treatment for seizures back in biblical times. And then all the way to the right there, you can see a photo of Dr. Wilder. He is a physician from the Mayo Clinic who was the first one to design the ketogenic diet as a treatment for epilepsy. So what exactly is the ketogenic diet? This is a diet that is high in fat, adequate in protein, and low in carbohydrates. It's calculated based on a ratio of the total grams of fat, protein, and carbohydrates. So what that means is if you have a 4-to-1 ratio, that means that for every 4 grams of fat that you're eating in the day, you have 1 gram of protein or 1 gram of carbohydrates. When you eat this way, it changes the way that your body uses energy. And so with a typical diet, your body is using carbohydrates mostly to break down to create energy. Now, during the ketogenic diet, the body converts fat into fatty acids and ketones, and then your body is said to be in a state of ketosis. Now, I do want to pause here and explain that the ketogenic diet as a treatment for epilepsy is different than a ketogenic diet that is now a fad diet. I think most of us would know somebody who says they're doing the ketogenic diet as it's now a fad weight loss diet. And the theory of the diet is the same between the two, with focus on increasing fat intake and minimizing protein and carbohydrates. However, the restrictiveness and the structure of the diet is quite different when using this for an actual treatment for epilepsy. So starting with this graph on the left here, this is showing you what a typical American diet is. So most Americans have about 55% of their diet made up of carbohydrates, with 15% being protein and then 30% coming from fat. Now, when you enter into the ketogenic diet, you're switching this, so you have 90% of the calories of the day are coming from fat, 3% from carbohydrates, and then just 7% from protein. So a big shift in the way that your body is intaking calories between the two. So who should consider this as a treatment for their epilepsy? The ketogenic diet is a first-line treatment for certain people who have a genetic metabolism abnormality that can lead to epilepsy. So for some genetic epilepsies, this is first-line therapy. But for others, this is a treatment option that can reduce the frequency of seizures that are not currently controlled with anti-seizure medications. This is used in children and adults with all different seizure types and can improve sleep and alertness. But, and this is a big but, this should not be initiated without the guidance and direction of both your neurologist and a nutritionist. And so for people who are considering the ketogenic diet, it's really important to be involved with a ketogenic diet or an epilepsy diet program. Not all epilepsy centers have dietary programs, but some do. And the ketogenic diet, when used for a treatment for epilepsy, is very restrictive, and it's difficult to maintain 100% compliance. Additionally, there are several side effects that should be considered, including nausea, vomiting, diarrhea, constipation, dehydration, weight loss, higher cholesterol and triglycerides, kidney stones, vitamin deficiencies, osteopenia, and growth failure. So for people who start the ketogenic diet, when they're followed by a nutritionist and a neurologist, these are things that they will be monitoring for and managing, as some are expected side effects from the diet. But I didn't want to paint the picture that this is a treatment option that minimizes side effects. It carries its own side effects, but is an alternative option for all people with epilepsy. There are some other lesser restrictive diet that can be used as treatment for epilepsy as well. So one commonly used is the modified Atkins diet. And again, the theory behind this is the same, where you're trying to have a low carbohydrate intake, high fat. This is less restrictive. It's easier to follow, especially for older children and adults who are really managing their own diet and caloric intake. There's no restriction on overall calories for the modified Atkins diet. You can have as much fluids as you want and as much protein. And this does not require fasting to begin. And then there's the low glycemic index diet, which also has overall no restriction on the amount of carbohydrates, but really ranks foods on a scale of 0 to 100. And that's the glycemic index. This number is based on the effect on the blood sugar of each of these medicines or each of these foods. Foods with a rating lower than 55 are considered appropriate low glycemic index foods. So then moving from dietary therapies to treat epilepsy, the next question that we often will get is, well, what kind of a diet should I follow in general? And I think that it's important to know that for all aspects of health, especially for managing your own health and your own medical conditions, including epilepsy, it is really important to be mindful of the food that you're putting into your body. But the recommendations are similar to for people with epilepsy when compared to people who do not have epilepsy. It's really important to eat a well-balanced diet, to have all of the food groups incorporated into what you're eating during the day, making sure that you're eating meals at regular times, avoid skipping meals. And then the last bullet point is really important: stay hydrated. A typical goal would be about 64 ounces of water daily. And as you can see here, I threw some facts because oftentimes we'll mention this in clinic and people will say, yeah, 64 ounces of fluid is fine. I can easily hit that with my daily routine. And so I like to point out that that's not always the case. So in the United States, between 2011 and 2014, adults in the United States drank an average of 39 ounces of water daily. And this is much lower for children. So between 2005 and 2010, US youths drank an average of 15 ounces of water daily. And what we know is specifically in adolescents, when they drink less water, they tend to drink less milk as well and drink more sugar sweetened beverages. So staying hydrated and drinking water is really important. The next question we get is, can food trigger seizures? And this is a really hard question to answer, and there's no really strong evidence against avoiding anything in particular. I always start by saying, be mindful of your own seizure triggers, because if you notice that every time you have something to eat or drink, you have a seizure or an aura, or you feel worse, then you want to be mindful to avoid that in the future. So that's really important, is individual mindfulness and knowing what your own triggers are. But some other common foods that we encourage people to limit, the first would be alcohol, and then caffeine, energy drinks, weight loss shakes, artificial sweeteners, and MSG. So I'm going to keep moving. Now we'll go over vitamins and minerals. Vitamins are chemicals that are needed in tiny amounts for your cells to function normally. Some vitamins are either made by our bodies and others are made by plants or animals, and we need to consume for our bodies. Disturbances in calcium, magnesium, and sodium can cause seizures, even in people without epilepsy. So it is important to be mindful of these things. But a note about supplements: more is not always better. I think that we've all had people who have cabinets full of vitamins on their shelf and have the mega vitamins and the minerals. And it is important to know that these, your body needs these vitamins in really small amounts. And so by taking these mega vitamins and really increasing the quantity of vitamins in your body can cause harm. Many of these vitamins are stored in your liver and your fat cells, and you can become toxic by taking too many or too much. If you do take vitamin supplements, you should talk to your doctor, whether that be your neurologist or your primary care doctor, about checking your levels and making sure that you need the supplement, or making sure that your levels aren't too high on whatever it is that you're taking. Now, we know that there is a link between certain vitamins and anti-seizure medications. Some of your anti-seizure medications can interact with the way that your vitamins are broken down in your body. And for this reason, your neurologist may recommend supplementing certain vitamins. And one of the more common ones is vitamin D, which is important for bone health. Some other vitamins that are important to note: the first would be folate, or vitamin B9. Low levels of folic acid increase the risk of birth defects. So this is certainly really important for women of childbearing age. All women of childbearing age should make sure that they have adequate levels of folate. And most women who have epilepsy and are of childbearing age should be taking a folic acid supplement. Some anti-seizure medications lower folate in your body, and so some folks need more folic acid than others. And so this is an important question when you're meeting with your neurologist, to ask if you should be taking a supplement, and if so, how much. Some other minerals to be mindful about that can either help or maybe be involved with your seizure medication. So the first is selenium and zinc. I put this first because a lot of people that we see in our clinic have hair loss as a complaint from many of our anti-seizure medications. And taking selenium and zinc supplements can be helpful to counteract that hair loss that's caused by these medications. Magnesium, low levels of magnesium can lead to headaches or seizures. So you may need a supplement here to help with either one of those. And for people who have a poor diet, or for those who have chronic alcohol use, it is common to have low magnesium levels. And then another really important mineral is sodium. So some of our anti-seizure medications, and some common ones such as carbamazepine and oxcarbazepine, can cause low sodium levels, and that's called hyponatremia. And this hyponatremia can worsen if you drink too much water. When you have hyponatremia, this can cause seizures, headache, tiredness, and confusion. And so if you are taking those medications, you should have your sodium level checked. And then one other compound to mention is ammonia. This is a compound of hydrogen and nitrogen, and the levels of ammonia can increase in your blood when you're taking certain medications. The most notable is Depakote, and that effect is compounded when you're taking Depakote with topiramate. So we might notice higher ammonia levels specifically with that drug combination. Evaluation and treatment of high ammonia levels can improve both energy level and thinking clarity. So it's important, if you're taking those medications, to potentially discuss checking an ammonia level with your neurologist. Next, a note on herbal supplements. So it's important for people to know that herbal products are not regulated as medicines. There is a significant risk here for either mislabeling or misbranding. And some of these may be helpful, but some may be harmful. And if you think of that combination of a supplement either being helpful or harmful and not being regulated, it does certainly lead to some concern here. Many of these can interact with your seizure medications. And so I added a list here. This is just some of the herbal supplements that are on the market that can increase risk of seizures. This includes black cohosh, ephrata, evening primrose oil, ginkgo biloba, guarana, kava kava, pennyroyal, star anise, star fruit, water hemlock, and wormwood. And then I purposely picked some of these so you can see really what these supplements are marketed for. And many of you may have seen these either on internet ads or in the stores. Many of these, black cohosh is marketed for the support of menopausal symptoms. Many people ask us about ginkgo biloba, which is supposed to help with brain health. And so these, again, there's some mislabeling here. The way that they're tested against seizure medications is not regulated. And so there may be significant risk. And these specifically have led to increased risk of seizures. And so if you're thinking of taking an herbal supplement, it's really important that you run that by your neurologist before you buy anything, before you spend any money on any of these supplements. And certainly if you're already taking them, you need to make sure that you're telling your neurologist what vitamins, mineral supplements that you are currently taking. Natural does not always mean healthy. And again, that big, bold bullet point, making sure that every doctor that's involved in your care knows what supplements that you're currently taking, and also make sure that you're running it by them before you buy it. So then I'll move on to the last topic here, and this is bone health. Now, some people ask, why do we really care that much about bone health when we're dealing with epilepsy and seizures? And the reason for that is because women who have epilepsy have an increased risk of bone fractures. This can be due to trauma related to seizures, change in strength and mobility, poor balance that can be caused by your anti-seizure medications, and osteoporosis. Osteoporosis is a disorder of the bone. And so when you think about your bones, bone is a living tissue, and it's constantly broken down and then built back up. Osteoporosis occurs when that creation of the new bone or the rebuilding can't keep up with the loss of the old bone. There are several risk factors for developing osteoporosis. Some of these you can't change, such as sex. Women are much more common to develop osteoporosis. Age, postmenopausal women are at increased risk. Race, being white or Asian, increases the risk, and family history. Some of these we can impact, such as hormones, vitamin deficiencies, chronic alcohol use, and medications. And then I highlighted that again because some of our anti-seizure medications can cause osteoporosis after long-term use. Osteoporosis is one of the silent conditions, meaning that it oftentimes goes undetected. It doesn't cause any symptoms until a fracture occurs. And then osteopenia, this is the stage before osteoporosis. Now, what is the link exactly between anti-seizure medications and bone health? Now, it's important to know that vitamin D is needed for your bones to absorb calcium and maintain their strength. So even if somebody has adequate calcium levels, without the vitamin D, the calcium isn't in the right place. It's not in the bones where we need it to rebuild that bone strength. And many of the anti-seizure medications that we use lead to vitamin D deficiency, which can increase this risk of developing osteoporosis. I listed a handful of examples here of some of the very commonly used anti-seizure medications that can lead to vitamin D deficiency, including Dilantin, which is phenytoin, phenobarbital, carbamazepine, primidone, topiramate, valproic acid, and oxcarbazepine. And so not only should you be thinking about vitamin D and bone health if you're taking any of these medications currently, it's also important to be mindful if you're no longer taking that, but you took carbamazepine for 10 years before, that may be something that needs to be evaluated. You still might need your vitamin D levels checked or supplemented or bone health monitored. So what can we do about this? Certainly, we check vitamin D levels to make sure that there is an adequate necessary amount of vitamin D in your body. If the vitamin D level is low, we certainly encourage starting a vitamin D and or calcium supplement. So this is something that you should talk to your doctor about. And then we recommend regular DEXA scans for people who are taking these medications. A DEXA scan is quite easy. It's an imaging study. It does not take long to do. And you can see how it's done on the picture on your right here. So you lay on a table and then it scans your body and it develops a score. And this score is a marker of how your bone density is when compared to a sample of people who are your age and your sex. And so a T-score above -1 is considered to be normal bone health or normal bone density. A T-score between -1 and -2.5 is what's classified as osteopenia, which again is that stage in between normal bone density and osteoporosis. And then a T-score less than -2.5 is considered osteoporosis. So some things that you can do in order to improve bone health are avoiding tobacco and soda, limiting caffeine and alcohol intake, participating in regular weight-bearing exercise to build that bone density, eat healthy foods with calcium. That includes milk, cheese, yogurt, leafy greens, seafood, and almonds. And our main source of vitamin D is from sunlight. So making sure that you're getting out in the sun is really helpful during the months of the year that it's nice enough to do so. Now, if you do have a DEXA scan and you fall into that osteoporosis range, then it's important to see a specialist for evaluation and treatment. And here, the rheumatologist or the endocrinologist frequently treat osteoporosis. Some primary care doctors are very familiar and comfortable with treating osteoporosis and would also be able to do a thorough evaluation and see if treatment is necessary. And then most importantly, especially for some of our younger adolescents and younger women, it's really important to make these changes now so we can prevent fractures later. If you think of the other risk factors for osteoporosis and bone loss, as we get older, postmenopausal age increases that risk. And so it's important for us to identify any of these issues early on and start to supplement or correct for them so then we don't compound these issues later as we get older. And that is my last slide. So I will thank you and stop sharing my slides and open it up for questions.
Thanks, Bethany. Just a couple of words, I guess, while we're waiting for some of the questions. This is a slide that I have presented in the past, and it's one of my sad slides. It tells us that as women, we reach peak bone density at age 25. And after that, it's downhill. So after age 25, we generally lose 1% of bone per year until menopause, when we can lose 5% in just 1 year. So if you do the math, you realize that, women can lose 50% of their bone health through their lifetime. In the United States, we are not good at preventive care for many things, but especially for metabolic bone disease with osteopenia or osteoporosis. And so many women actually don't get their first DEXA scan until after menopause, or even worse, after they have fractured their hip. And so we know for sure, though, as Bethany told us, that low bone density can be reversed. So if it's noted early that there's a problem with bone density, there are treatments to reverse this. And many people, if they're discovered early enough, will get back to having normal bone density by the time they have to go through menopause. So it's really important. As Bethany said, we do care a lot about bone health, but I must say that it's probably not on all physicians' radar. So it is probably important for you as well, if you have not had a DEXA scan, to just remind your doctor that that you need to have that done. Let's see, how are we doing? Oh, yes, and actually I wanted to talk about this too. So this came up actually, essential oils can cause seizures, and I was very surprised by this. But had a patient who presented, and it turned out that they were using essential oils. They were actually had one of those things that would put it into the air, so they were smelling it. So essential oils, while good for some things, can trigger seizures. And it turns out that the list of essential oils that can trigger seizures includes rosemary, fennel, sage, eucalyptus, hyssop, wormwood, camphor by itself, and also spike lavender. And it turns out that spike lavender is a little bit different from regular lavender because of its camphor constituent. It has a higher level of camphor. Camphor is actually a brain stimulant, and so that is the mechanism by which it can cause seizures. So I thought that was actually kind of interesting, as essential oils are really very popular for many people. Oh, yes, and we're going to leave Eleanor up here while we go through the questions. And this is one of my favorite quotes from Eleanor Roosevelt. Women are like tea bags. You never know how strong they are until they're in hot water.
Great. Thank you, Joyce and Bethany. So we did have quite a few questions pop in. So we'll go ahead and get started. The first one is there a ketone level that you should target while using a keto diet?
Yes. So when the ketogenic diet team is following you, they look for a level above 1.5. But I would certainly, again, you'd be followed closely by the team, and they would be able to give you what your specific target is. But general rule of thumb, 1.5.
Okay, perfect. Thank you very much. And another one is, I know Joyce had touched on this a little bit, but what are your thoughts on essential oils?
Yeah, I think Joyce is much better to answer that than I, and I think she did a really good job with her slide. Certainly, we have patients that have found them helpful. I think that over the past several years, they've become much more commonly used. And I tend to think of them similarly to herbal supplements, knowing that when you're starting to use any of those, some may be helpful, some may be harmful. Know what your triggers are. If you identify something that you think makes you feel unwell, avoid in the future. But until there are some better studies about all of these things, I think it's hard to make broad statements.
Yeah, absolutely. I agree. You know, it's interesting. Just as I was leaving Jefferson about 15 years ago, they were doing an experiment, research experiment on use of lavender oil during MRI scans to see if they would get better pictures. You know, as people on this Zoom know, when you have an MRI scan, you're in a very enclosed spot, and it's important to not move so that you can get good pictures and have good resolution on the screen. But that's hard to do when you're inside a little tunnel. And so they proposed that potentially if people would have lavender oil, that they wouldn't necessarily need to take medications to relax them, that they could just use the essential oils. And I actually have never seen that published, but some of my patients participated, and they did say that they found it actually very relaxing. They were able to get through a scanner with less difficulty.
Perfect. Thank you very much. So we did have we have plenty of questions. The next one is, what are symptoms of vitamin D deficiency to check for?
So some people will attribute vitamin D deficiency with energy. I personally think of vitamin D deficiency as oftentimes silent. I don't think that there are very common side effects that people attribute to that uniquely. And I think that makes it all the more important to be asking about it and to be monitoring for it. It's not something that we rely on symptoms to tell us when we should be looking for that. And so if, concern for vitamin D deficiency, and one of the other plugs that I'll put here is that people in this area of the country, because again, keeping in mind that the vitamin D best is absorbed from sunlight, and knowing that it's cold and we stay indoors for more than half of the year in this area, there is increased risk for vitamin D deficiency anyway, outside of these seizure medications. And so it's probably one of the more common things that we pick up on our routine lab work is a vitamin D deficiency. And more times than not, there's really no symptoms associated with that.
Yeah, I'd like to add that, vitamin D was actually misnamed. And now that it has that name, no one will ever change it. But vitamin D is actually a hormone. And so a hormone is defined as a product that's made in our bodies in one place and acts somewhere else. So we all make vitamin D when we are exposed to sunshine. Turns out it takes about 30 minutes of sun exposure per day to make enough vitamin D. And then, of course, you have to worry about things like skin cancer. So many of us are actually very, very much vitamin D deficient. There are links with vitamin D with many, many things. So definitely, as Bethany said, bone health, energy. There's a thought that perhaps low vitamin D can be linked also with heart disease. It's been linked with memory loss. It also has been linked with small for gestational age babies and preterm deliveries. So I tell people I respect vitamin D a lot. I think that if our bodies make it because we're exposed to sun, there's something very basic about that is telling me that we all need to make sure we have adequate vitamin D. So I think it's important to have that checked.
Perfect. Thank you very much. Looks like we had the next question is, can a girl teen with epilepsy take DEXA scan?
Yes. I think young adults, teens, especially if taking these medicines, should for a long time, which if people have epilepsy from babies or young childhood, they may be on these medications for some time by the time that they're in their teen years. Certainly, we don't do DEXA scans if anybody is or may be pregnant. So that's certainly something that we would screen for. But otherwise, and assuming that they can sit for that scan. So again, you have to, lay on the table, legs are up. And so we've had some of our more behaviorally complicated patients that can't tolerate the study. But other than that, we do them routinely in our teenage girls.
Yeah, I must say I have had some pushback from insurance companies in my younger patients. I do just send them some literature telling them it's a standard of care. When people are younger, they usually get a Z-score instead of a T-score. So a T-score is your bone density compared to women at peak bone density, which we said was 25. So, I feel sometimes that's unfair when I'm getting my DEXA scan. For women who are younger than 25, the standards really aren't as well studied. And so instead people get a Z-score, which is your bone density compared to other people your age. And also for what's normal and abnormal is a little bit different with a Z-score compared to a T-score, but it certainly can be done. Just sometimes the insurance company will need a little extra nudging to approve it for people certainly younger than 18.
Perfect. Thank you. The next question we have is, what foods can reduce estrogen, given estrogen is a catalyst in seizures?
There are, I think, a few food groups that can reduce your body's levels of estrogen. Certainly, we usually think of some vegetables like broccoli and cauliflower. I think some grains can as well. And, we oftentimes think about the link between estrogen and seizures, but I also like to make sure that we're not getting too caught in the weeds with that, right? I think that having a healthy, well-rounded diet without you know, if you try to line up all of these different things that we're talking about right now, I think you drive yourself insane. How do I keep my levels of estrogen low with my diet, but also maybe not have too many carbohydrates while avoiding caffeine? You know, I think that my main take home point for that would be if you have a well-balanced, healthy diet, it will incorporate some of these foods that we typically think of that would lower levels of estrogen. But I don't personally make recommendations for diet based on that.
Okay, great, thank you. And our next question is, which is more important, getting natural vitamin D from the sun or lowering risk of skin cancer?
That's a really good question. And, you know, every time I say we absorb vitamin D from the sun, I think about that caveat, because you know, you can supplement your vitamin D. I would never, ever recommend, you know, going to sit and burn in the sun without SPF. And your absorption of vitamin D with SPF would be blunted. And so, you know, it is a complicated question. Anytime you go out into the sun, always SPF, always protecting against skin cancer would be number one in my books. But again, being mindful that if you are, you know, fair skinned, not out in the sun a lot, acknowledging that you may be more at risk for vitamin D deficiency, and then checking that and then supplementing if needed.
Perfect. And our next question is, what's your opinion on vaginal estrogen suppositories that women use for menopausal symptoms?
Okay, so again, I would rely on my, you know, bullet point about knowing your own seizure triggers, because for some people, even though we know that estrogen can increase risk of seizures, some people tolerate it quite well and don't have any increase in their seizures with this. And for anybody who has menopausal symptoms, that can also be very life, you know, bothersome in their life. And so you have to, you know, weigh the pros and cons. I think sometimes the severity of somebody's epilepsy plays into that discussion. And then really kind of making that decision based on what your clinical history is important. I can say that we've had patients and do have patients who are on estrogen supplementation. Most of that's vaginally, and they do fine.
Wonderful. Thank you very much. Our next question is, we often hear that magnesium can help with seizures. What are your thoughts? Is magnesium something that can be checked with blood work?
So typically, I'll answer the piece that I'm comfortable with, and that is magnesium absolutely can be checked with your blood work. It does not usually, it's not a part of the typical basic or comprehensive metabolic panel that we draw, and so it would be an additional test. Most commonly, we supplement that for headaches. And certainly derangements in magnesium. So if you were to have, you know, a sudden drop in magnesium levels, that can lead to seizure. But I actually have not heard or don't know that it's helpful for seizures to supplement. So I would toss that over to you, Joyce.
Yeah, so, you know, it's common practice for eclampsia or preeclampsia. So many of the OBGYNs will use that first if they have a patient, a non-epilepsy patient who has high blood pressure, spilling proteins in their urine, and they're concerned that they're having a condition called preeclampsia. And then if they actually have a seizure, it's eclampsia. So what they use very first for preventive is magnesium. And magnesium can turn things around for these women. I must say that I use magnesium a lot in my migraine patients, I guess, as you do, Bethany, but I really don't suggest it in our epilepsy patients. It's just not routine practice. Magnesium is checked on your metabolic panel when you have your blood work done. It's interesting though, magnesium can be challenging to measure. And if you just check a serum magnesium, that is probably not really going to reflect your magnesium stores. And so instead, you're supposed to check a red blood cell magnesium, which is not a typical test. So that would have to be ordered separately if there was an issue. Alcohol is something that lowers magnesium. We see lots of people coming in to the emergency department who have seizures after they stop drinking, and often they also have low magnesium. So they're given magnesium supplement as well to help not only with seizures, but to help with any potential withdrawal for memory concerns. So that's pretty standard practice.
Great, thank you. Our next question is there any correlational / causal relationship between removing a molar tooth, a healthy tooth for purpose of aligning and straightening teeth, and a seizure, even though the seizure may have occurred several years after the tooth removal?
I don't think so. Not that I can't think of a correlation there. So I would say no.
Okay, great. So our next question is, speaking about tea bags, how about the herbs in tea? Does it cause seizures too in some teas? Lemon, ginger, raspberry teas, lemon tea, all decaf, peach tea. And then also, does sparkling water, flavored, carbonated, cause bone loss? This is a drink with no sugar.
So regarding teas, every example of teas that was listed in the question would be okay. Flavored teas, okay. But I think it's a great question because there are herbal teas with supplements in there, and that's another way of ingesting these supplements. And so if you're taking anything other than naturally flavored teas or anything else that's labeled natural, specifically, like I've seen some marketed brain health teas or anything from the health food store, I think it would make sense to run that by your physician before taking it. And just really read the labels, know what's in it when you're taking it, right? Like a regular black tea or green tea that's just flavored would be okay as long as you're monitoring your caffeine intake. But there are some other herbs that are in teas that may be harmful and you may want to be more cautious with.
Great. Thank you very much. Our next question is,
Hang on a second, Seamus.
Oh,
I'm not quite sure we've completely finished. They also asked about the
yes,
sparkling water flavored carbonated beverages causing bone loss.
Oh, I don't actually know the answer to that question.
Yeah, so, sodas cause bone loss, but that's because your kidney needs to attach a little bit of calcium, and you lose calcium when you drink any sodas. I'm not sure if it's also true for carbonated beverages. I know carbonated beverages in the sparkling water can cause problems with your teeth. And so it's this, you get a little paranoid as you answer all these questions because really nothing is good for us. But you could speak, you could speak with your dentist about that if you're drinking a lot of that. And it is, of course, good to drink unsweetened, no sugar beverages.
Awesome. Thank you, Joyce. The next question is, what is adequate vitamin D?
So you can check a vitamin D level, and typically a normal vitamin D level is 30 and above. So we tend to like to see that.
Yeah, and I just, I'll say a couple of words about that. Vitamin D happens to be one of our fat-soluble vitamins. And so as Bethany said, if a little is good, it doesn't really mean a lot is better. Some people think, oh, I have osteoporosis, I'm gonna take 100,000 international units of vitamin D every day. That for sure will lead to toxicity. And so for most people, I kind of target a level of 40 to 90. If people get to about 80, I tell them they should really back off because we don't really want to see anybody over 100. I've only, in my 30 plus years of working, have only seen or recognized one person who had vitamin D toxicity. She was a real mystery. in the hospital, she couldn't walk. She could barely raise her arms up. And this had kind of come on very gradually. And eventually we figured out that she was taking large supplements of vitamin D, and we checked the level and it was in the toxic range. It was over 200, which I had never seen before. Her treatment was simply stopping her vitamin D, and she was fully ambulatory again, could walk, could exercise, and could do anything she wants. Generally, for a daily intake is about 2,000 international units a day of vitamin D3. Sometimes if you have a low level and you're trying to bump that up, many people will be given a prescription of vitamin D2. Well, they'll take 50,000 international units weekly for anywhere from 4 to 6 weeks, and then continue to supplement just with vitamin D3, which is over the counter. If you are just a little low, let's say your level's 38 and you just need to bump it up a bit, I will often put people on 4,000 international units and then just kind of recheck. It's pretty easy just to get a vitamin D level checked. So anywhere from, I think, 2,000 to 5,000 if your level's low. And then once again, sometimes you're given a little boost in the beginning to really get the levels up there.
Okay, great. Thank you very much. Our next question looks like this is towards you, Joyce. What did you mean when you said bone density can be reversed? I've had osteopenia for years due to use of anti-seizure meds. Does weight-bearing exercise, getting sunlight, and taking vitamin D reverse bone loss or prevent it from progressing?
Yeah, it can do both. So things to help with bone loss are no sodas. And so actually, earlier Missy had asked me when we started this Women's Health, and it must have been pretty close to 1988 or 1999, because that was the year that I gave up drinking soda. And I remember one of my kids was quite young, and he was very upset that I wasn't giving him soda anymore. But that was from this conference. And so soda is bad for your bone health. So you should definitely give up soda. Other things that are bad for your bone health are coffee, which I have not given up, alcohol, high protein diets. So there are a lot of things that are important for bone health in our diet. Certainly weight-bearing exercise, which is basically any exercise except for swimming, can help reverse bone loss. And for those of you who have participated in the epilepsy walk, once in a while, I will strap some ankle weights on as I'm walking, because that can help with bone density too. And so all of those things are helpful, but in anyone who has osteopenia or osteoporosis, I send them to the rheumatologist in general. You could also see the endocrinologist or your gynecologist to learn more about medications that can be used to treat and reverse low bone density. So there are many products. So in the past, it was always Fosfamax or Boniva. Those medications sometimes have some side effects associated with it. There are now intravenous and intramuscular treatment options. Prolia is very common. It's given as a shot in your arm every 6 months. There's Reclass, which is a once a year intravenous treatment, but people can actually reverse their bone density before they get into trouble with it. And many people can actually get a DEXA scan and see that they have, instead of losing bone, they've actually gained bone 5%, 8% in just 1 year. So you can imagine over the years, you can get to a point where your bone density is back to normal instead of showing osteopenia or osteoporosis. That's why it's important to get your DEXA scan checked.
Perfect. Thank you very much. Looks like our next question is, what needs to be monitored with Oxtellar extended release?
So oxtalar is extended release oxcarbazepine. So that would be one of the medications that can lower your sodium levels, can also lower your vitamin D levels. And so a metabolic panel would look for the sodium and then an additional vitamin D level to assess for any supplement that should be taken there.
Perfect. And our next question is drinking greater than 64 ounces of water each day damage to you?
That's a great question. So I actually, in preparing for this, was looking at the CDC for a fluid intake guideline, and there is not one that they recommend across the board. 64 ounces is kind of thrown around in a few of their websites. But yes, I think as a general rule of thumb, not more than 64 ounces, again, because there's no, gold standard, but too much fluid, just like too much vitamins, too much water can also be harmful. And there is such thing as water intoxication. So if you remember the slide that I had up there about sodium, one of the things that can lower your sodium levels is by drinking too much water, because you dilute the minerals that are naturally in your body. And that runs its own risks. And so I would say, when you're depending on your body size, 64 ounces, going significantly over that with water intake, you'd probably want to run that by your doctor to kind of see what's good fluid intake for you, for your body size. I think that how much fluid are you excreting during the day, right? Are you a exerciser? Are you sweating a lot? Do you need to replenish? All of those things will play into that. And so again, using 64 ounces as a general rule, but being mindful as you go over that, that there may be some risk to substantial amounts above that.
Perfect. Thank you very much. Our other question is, why does green tea trigger seizures?
Well, I think, first of all, caffeine can be a seizure trigger for some people. But again, I would say that's, one of these nitty gritty nutrition questions where there could be risk with anything. But in general, I would say if you can go decaffeinated green tea over regular, that would be better. But I don't think that there is risk for everybody with green tea. Again, know your own individual seizure triggers. If you notice that drinking green tea has provoked things for you, then you should avoid it in the future.
Great. Thank you very much. And everyone, just a quick real heads up. We are on our break, but we do still have time for questions. So our next question, I believe, is hair loss supplements that should be taken, or they're maybe asking, are there hair loss supplements that should be taken?
Yeah, so we mentioned zinc and selenium for a lot of the hair loss that's caused by anti-seizure medications. We will oftentimes recommend a zinc and selenium replenishment or supplement. Also, taking a biotin supplement, some people have found that helpful, and that would be okay. Again, anything that you're taking, you just want to make sure that you're making sure that your treating neurologist or primary care doctor knows the supplements that you're taking, regardless of what they are. But those are the more common ones.
Okay, great. Wonderful. Thank you very much, Bethany. We appreciate it.
Sure.
No other questions right now at this time.
Actually, Seamus, I think we missed one.
Oh, did we?
There was one that says, does tamoxifen, which is an estrogen agonist and antagonist, does that increase the risk of having a seizure?
Not that I know of. I don't think that there's any clinical studies showing risk between tamoxifen and seizures, increase in risk.
Awesome. Thank you very much. All right, everyone. Well, thank you, Bethany, so much. That was a wonderful presentation, and we really appreciate it. And our next speaker will begin at 12:15.
Thank you.
back, everyone. We've had 3 great, wonderful presentations so far, and I hope everyone is ready for our next wonderful speaker. So I am going to hand it over to Joyce at this time to introduce our final speaker of the day.
Thanks very much. So it is my pleasure to introduce Dr. Jaime Spinell Zuckerman. She is a Philadelphia-based licensed clinical psychologist in private practice on Lancaster Avenue in Ardmore, Pennsylvania. She received her undergraduate degree from The Ohio State University and her doctorate in clinical psychology from LaSalle University. She completed her internship and postdoctoral fellowship at Long Island Jewish Medical Center in New York. She utilizes both cognitive behavioral therapy as well as acceptance and commitment therapy in her approach to the treatment of adults with mood disorders, anxiety, and adjustment to illness. Dr. Zuckerman specializes in relationship difficulties with a focus on helping those involved with narcissistic partners. She is a frequent presenter for the Epilepsy Foundation of Eastern Pennsylvania, as well as the Dravet Syndrome Foundation. Dr. Zuckerman is also very frequently seen on several media outlets, including television, radio, podcasts, and various online publications. And I am really looking forward to her talk, which is entitled Managing Stress During the Pandemic. So thank you very much for being here.
Hi, thank you for having me. Okay, let me share the screen. Did I get this right? Okay. There we go. Okay. Great. Okay, so thank you everybody for having me. I'm very excited to talk about this, especially given our recent climate over the last year. So we all have stress regardless, and then throw a pandemic on top of it. And it's a recipe for some big anxiety. Okay, so this is a quote I like to give always in the beginning of presentations. The single most remarkable fact of human existence is how hard it is for humans to be happy. And before I even get into this, one of the things that I like to say to people is that when you are dealing with any type of life circumstance, it's normal, it's the human condition to have anxiety, to have stress, to have sadness, and our efforts to stop those very natural emotions are usually what ends up being an anxiety disorder or a depressive disorder. It's that struggle against it rather than that willingness to sit with it and let it pass naturally. Okay, so let's move this so I can see better. Oops. There we go. Okay, so managing stress during the pandemic. We're going to talk about 2 main groups during this. And the first is those who have been diagnosed with epilepsy, and the second, those who are caregivers of those diagnosed with epilepsy, because during this very stressful time over the last year and more, it's not just patients with epilepsy. It is also very much their caregivers and who are the ones that are going out, getting medications, getting food, taking care of schedules, taking care of doctor's appointments. So in general, what is unique about epilepsy with regard to stress? So there's a couple things. First is the reaction to the illness itself. A lot of times when I work with patients who have recent diagnosis of epilepsy, there's this sense of lack of acceptance, this initial lack of acceptance, which is very common actually with many illnesses. This kind of pre-diagnosis and post-diagnosis life, and it's this acceptance of this change in the path, let's say, that you thought you were going to go, and now that you have a diagnosis, things have to take a little bit different of a course. So there's a large acceptance component to that. Difficulty adjusting to epilepsy in general. Stigma and discrimination. As we know, a lot of times people are uneducated about what epilepsy is, what certain types of seizures look like, how to handle it. And it can be very scary to not only the person who has epilepsy, but also the people around them if they don't know what to do. There's also lack of control caused by random seizure occurrence and lack of social support. So epilepsy is one of those illnesses where I can see people that have been seizure-free for 30 years, but if you ask them what their biggest angst is, they're still going to say, what if I have another seizure? Or what if my cocktail of medications all of a sudden stops working? So day-to-day stress of epilepsy prior to COVID. So obviously stress about epilepsy didn't just begin when the pandemic hit, but you're routinely making appointments and special arrangements with your team, therapists, neurologists, and so on. It becomes a part of your, I don't want to say day-to-day, but it becomes a part of your schedule. There's also issues of memory concerns, driving restrictions, the job of educating others, which can feel very daunting at times, especially depending on who is in your support network and even outside of your support network at work, at other family events, when you go to college. Foods and diets are a big component to this. How do you function as a parent and have epilepsy? How does that affect your role as a mother, as a father? Your career. A lot of times there may be times where you need to call out of work. What do you say? Do you feel comfortable saying that you have epilepsy? Do you feel comfortable saying why you're out? Do you explain yourself to your colleagues? How do you explain yourself? What if you're surrounded by people who you don't want to explain this to or who won't understand? Medications is always a big stressor. Recovery periods and rest. Rest is a big thing. You must implement rest across all your day-to-day activities because, as you know, the more overtired you get, the more fatigued you get, the more stressed you get, you put yourself at risk for seizures and just feeling bad in general. So particularly with women, women continue to worry about their day-to-day responsibilities and how their diagnosis will impact them. And when this happens, they can experience a drain on emotional well-being that may impact them for some time to come. Again, because you're dealing with a condition that has a lot of kind of this sense of lack of control surrounding it and this kind of uncertainty. It's on this intermittent reinforcement schedule, meaning you just don't really know when, how, and what. And when you're dealing with any type of situation that has that intermittent nature to it, it naturally is going to cause more anxiety. So in general, when you are managing an epilepsy diagnosis, you can't just turn it off. You have to make sure that you take time for yourself, particularly during this pandemic with all the stressors that are involved in that, which we'll get into. It continues, and it's even more important now to be able to take time for yourself, whatever that looks like. It could be just sitting in your room by yourself for 5 minutes. It could be just taking a walk to get the mail. So let's first start with young people with epilepsy. So when we're looking at the pandemic and we're looking at epilepsy, in addition, like I said, to situations that cause stress prior to the pandemic, they don't go away. And if anything, they're more pronounced now. So the first thing to look at is dating. When you have young people with epilepsy, young people are starting to get into dating others, starting to make plans with their friends to see other people. And it starts to be a time when low self-esteem starts to come to the surface, when insecurities start to come to the surface. So it becomes an issue of how you communicate, especially with young people, to your friends or people that you're starting to date. How do you communicate to them about epilepsy? How do you communicate to them what it looks like, or how it develops, or what should they do if you have a seizure while you're with them? What happens if you are sick for a couple of days or your medication's giving you side effects? So these are all things to think about, particularly in the social environment that we're in, and particularly with social media today. There's also increased academic demands, obviously, as a young person enters into college, enters into grad school, enters into the work world, and because of cognitive difficulties that can arise with an epilepsy diagnosis, this can cause a lot of added stress. Driving, obviously, is always a big one. Driving is a significant form of independence, and young people at this age in particular are craving independence. They are trying to do everything they can to break free from their families, from their parents, and driving is one of those ways in which they do that. So to have limited driving abilities, or to have your license revoked or not be given to you, or need somebody with you, this can really foster a sense of feeling out of control or feeling different from their friends. And also, going into college in general, we always worry about alcohol and drug use and overuse. This becomes even more important when you are on medications for epilepsy. Okay, so COVID and epilepsy. There are a lot of different factors involved in this. There are a lot of different groups involved with this. So I'm going to kind of pick this apart group by group and talk about how COVID in particular is going to affect that group when we're talking about epilepsy. So essential workers versus caregivers. If you have a caregiver, let's say, who is an essential worker, who stays home if help is unavailable to come to the home? If somebody needs to go to work, if the primary caregiver needs to go to work, who's going to stay home if the other person is either home from work because they're not allowed to go in, or their kids are home from school? It becomes a really stressful situation. And I saw this a lot in my practice, this kind of juggling act of who is going to stay home. Also, single parent households. If your children are home, you have nobody to watch them, you need to go to work. Or if you can't go to work because you are sick or because you have a seizure, who's going to be taking care of the kids when the kids are not in school because of COVID? And I'm sure this was spoken about, but as far as a compromised immune system, people with epilepsy are likely to be at a little bit of a higher risk because of this. And so they have to take greater precautions. And this is going to mean more isolation. And with isolation, as we know, comes increased depression and increased anxiety. And again, if you need to stay home, and let's say you're married to somebody or your caregiver is an essential worker that had to go in, and you need somebody to stay home with you, who's going to do that? If you can't drive, who is going to take you places? So all of this becomes something that is not just a one-person issue, but it becomes a systemic family issue as well. And within your support network. You're already at a higher risk for injuries. And so what happens if you injure yourself somehow and you have to go to the emergency room? Now you're putting yourself in a situation where you're in an emergency room when there is a pandemic going on. So again, it's kind of put you in the situation where you're already at higher risk, but yet if you get injured, you need to again put yourself in a situation with higher risk, and it becomes just this back and forth battle. And then just because there's a pandemic doesn't mean that illnesses just cease to exist. They still exist. Doctor's appointments still need to continue. Your scans still need to continue. Your blood level checks still need to continue. You don't stop taking your meds just because there's a pandemic. So all of these things become not just everyday stressors, but now they become stressors plus a higher level of danger associated with them. Plus just the day-to-day, who's going to take me, who's an essential worker, who's home, how am I going to get there? Also, important lifestyle adjustments. What happens if you have a medication change during the pandemic? How are you going to get your medications? You need to go to the doctor, which means you're placing yourself in a doctor's office during a pandemic. Same again with ER visits. Dietary needs in epilepsy is a very big component. How are you going to go to the market? Can you go to the market? Certain specialty stores have been closed and still remain closed. Delivery times have been exceptionally slower. Things that maybe took a day now are taking a week. What if it's something that you need immediately that you used to overnight? Again, if the person who drives you or is your caretaker can't get there because they're at work. So again, it leaves this kind of gap where nobody really thought about any of this because we've never had to. And now that we're in this situation, things, like I said, even down to Amazon delivery time or mail-in prescription times are significantly slower. So it's just another thing that has to be remembered or thought about. So we talked about compromised immune system. So virus transmission, again, is a concern for everybody, but in particularly people with epilepsy. Financial fears. This was true for everybody. However, again, when you're dealing with an illness that is something that you are always going to have, your medical bills, your health insurance are always variables that are kind of in the forefront of your mind. So during COVID, what happens if you lost your job? What happens if your spouse lost their job? Your parents lost their job? How are you paying for medical bills? What are you doing now for health insurance? And again, what we know about stress and epilepsy, the more stress you have, higher risk you are for putting yourself in a situation where you could have a seizure. Maintaining a safe household, again, is always something that we want to be aware of. But what happens when there's a pandemic, people are not working? Now you have way more people likely in the house, including maybe younger siblings who aren't the most careful. A spouse is home when usually they're traveling, let's say. So you're used to having your household set up a certain way with safety in mind. And now, as I like to say, there's too many cooks in the kitchen. And with that, you have to maintain the safety precautions that have always been there. So it involves a lot of education. It involves a lot of eyes. And it can be, again, a daunting task. Changes in routine. We all have had significant changes in our routine since last March. And as creatures of habit, we don't like changes in our routine. And when we are dealing again with an illness such as epilepsy, routine and structure are so important. One, sleep. When sleep schedule gets thrown off, you know, it's one of those things, again, lack of sleep that can put somebody at risk for having a seizure. Not taking your medications in the right order or at the right time, not eating at the right schedule. If you have an exercise routine in place, not doing that in the same routine anymore. So it really kind of, again, takes additional energy and a lot of effort to maintain your schedule as is. Now throw a pandemic into place where everything is up in the air. Can we go out? Can we not go out? Do we wear a mask? Do we not wear a mask? Should I go out at all? Should I not? Should I allow this person in my house? Should I not? I can't get to the pharmacy. The pharmacy can't deliver in time. So changes in routine are unavoidable during the pandemic. So it's very important to, as best as you can, maintain what I like to call as much of your pre-pandemic routine as you possibly can. Okay, so again, just like illnesses don't stop during a pandemic, neither does wanting to have a child, neither does being a parent. So let's talk a little bit about family planning and pregnancy during COVID. One, it would be normal to have more anxiety about this during a pandemic. It would be normal to worry more about this during the pandemic. And it would be normal to want to contact your doctor more frequently than before the pandemic. And again, all normal. So one of the things that we have to keep in mind during family planning stages, early and during pregnancy, during COVID, routine doctor appointments. Again, you are putting yourself in a situation where you are likely going into a facility where people are sick. Even something like, do you stay in the hospital when you're giving birth? How is that going to work? Who's allowed in, who's not allowed in? Is it going to put you more at risk for having a seizure? Is it even something to consider having the child at home? Which again, because you have a medical illness, probably would not be the smartest thing to do. So you do have to be in a hospital. So again, it's all these kind of new ways of navigating your environment that we never would have thought of before. Then there's this decision of delaying pregnancy. And I worked with actually a couple women on this who were trying to get pregnant. The pandemic hit. And then there was the discussion of, well, should we delay pregnancy? Should we delay trying? And I think most of them did, actually, now that I'm thinking about it. However, it's not just as simple as we're going to delay trying for a baby because of the pandemic and the virus itself, but also maybe a spouse or significant other lost their job. So having a baby now is too much financially for the family to handle. Let's say that you have fertility issues. Fertility issues involve going to doctors, going to so many checkups constantly. So again, you're putting yourself in a situation where you have to go into a doctor's office, you have to go into a hospital where you're higher risk when there's a pandemic going around. And fertility specialists, all of their procedures are very time sensitive. So if you delay, there's that idea of, you're putting it back months and months and months. We're not talking just a month. People that wanted to adopt ran into this. There were significant adoption delays. And this was very hard on people because it's already a process as it is, put a pandemic into the mix, and the delays were kind of push people back years. And again, I already talked about fertility treatments, but the timing aspect of fertility treatments is so sensitive. And so when people make the decision to delay when they're dealing with fertility treatments, it's a very big and sometimes very upsetting decision to have to make. So let's talk a little bit about the impact on the lives of caregivers during COVID. In general, they're going to have much shorter socialization, much lower visiting times with friends. This is due to social distancing and the restrictions that are there, because obviously if you are a primary caregiver for somebody, you have to be very careful where you go, who you see. Do you go to the market? Again, do you go to the pharmacy? Do you go to your doctor's appointments? Do you go to other family members' houses knowing that you're going to be coming home to your home? Regularly scheduled appointments that you would have if you were a caregiver, let's say that you're on a very strict schedule with, now once again are up in the air. Let's say every Wednesday you went to the gym because that was the time that you were able to go. You can't go anymore. You can't get your hair done. You can't cook meals the way you wanted to with the types of food that maybe the diet allows for, because you can't get to the specialty stores. Even things like book club, your social outlet. Let's say that every week you had a book club on Wednesday nights. You can't go anymore. And yes, people got creative. There were book clubs on Zoom and we did things over FaceTime, but it still really is not the same. And also remember, like I said before, there's more cooks in the kitchen now. There's more people home in the household. Also, people lost their jobs, so they may not be able to go to the salon. They may not be able to go to the gym, even more so than taking care of somebody, let's say, who has epilepsy or any illness for that matter. There's a huge financial component to this as well. Any in-home help or aid may have been halted because of COVID. Let's say that you had somebody come into your house to help you, to give you an hour to yourself, but now they're not coming for whatever reason because of COVID, or they got sick or someone in their family got sick, and so therefore they can't go to work, they can't come to your house because they were potentially exposed to somebody. So it's not just you and a spouse, you and a caregiver, you and a child. It's everybody else around them, which prior to COVID wasn't even on our radar. So mental health, obviously mental health this has a huge impact on our mental health. There's significant increase for anxiety and depression as a caregiver and a person with epilepsy, which is even higher for all the reasons that I spoke about during COVID. More social isolation, lack of finances, fear of loss of job, weighing the cost-benefit analysis of pregnancy, of my meds aren't working. Do I go to my doctor's appointment? Do I do a telehealth visit? Who's going to take me? The idea of no one understands me, this is something that is very common with people with epilepsy. And during COVID, this became an even bigger concern because while people were maybe taking some risks that they shouldn't have been, people with epilepsy and their caregivers really were taking none. The impact that this has on marriage, is substantial. There's again more cooks in the kitchen, so there's more fighting between family members, there's more stress, there's more anxiety, and whenever that happens, combine it with job loss. We know that people were drinking more during the pandemic. We know people were at increased risk for drug use during the pandemic. So all of this together is going to have a significant impact on family. And then worry, like I talked about, worry is inevitable, and that's why I said in the very beginning that it is normal to have worry and anxiety during this time. And if you didn't have any anxiety and worry, I'd actually be more concerned that there was some sort of heavy avoidance going on. So worry about finances, job, insurance, and health are all there prior to a pandemic when you have an epilepsy diagnosis, but even more so now. Some common psychological conditions in women with epilepsy. Again, these top two, depression and anxiety, got considerably worse during the pandemic for all the reasons that I spoke about. Mania, psychosis, and personality disorders. The one thing with personality disorders that I always just like to say is that sometimes what appears to be a personality disorder in someone with epilepsy could very much be due to a side effect of medication. And so it's very important for psychologists, mental health providers to look at the signs and symptoms and see if they had been there way early on in the person's life, or if it's something that started more recently since they had been on medication. Suicide rates, we know, 5 to 10 times higher in people with epilepsy, and it's up to 25 times higher in people with focal impaired awareness seizures versus the general population. Suicide rates also did increase in general during the pandemic, so that did increase as well for people with epilepsy. So some quick facts related to caregiving in general, I just want to talk about before we go forward. Family caregivers who provide 36 or more hours weekly are likely than non-caregivers to experience symptoms of depression or anxiety. For spouses, the rate is 6 times higher. For children caring for the parent, the rate is twice as high. That's a lot. When you're looking at illnesses in general, this has one of the highest rates. Common symptoms, again, associated with caregiver stress. I touched on this, but again, I want it to be known that these symptoms, depression, helplessness, hopelessness, anxiety, all escalated during the pandemic. So conflict with spouse, children, and extended family. This is something that I saw a lot of in my patients who have epilepsy during the pandemic. There was just, again, all of that extra stress, everything down to delivery times are slow, to loss of job, to decreased socialization with friends. It caused a tremendous amount of conflict within the home. Unfortunately, domestic violence rates went up, and child abuse rates did go up as well. However, in the very beginning of the pandemic, there was a press conference, and I remember watching this, and I wanted to jump out of my skin. They were saying how the rates decreased of child abuse. And I remember sitting there, you know, kind of, that's not true. And instinctively, I know that's not true. And the reason for that was because schools were closed. So children weren't going to school. Therefore, there was nobody reporting it. So initially, it looked like it was going down when that actually was the opposite. There's a lot of shame that's associated with caregiver stress, that they feel angry, they feel like they're missing out on things. They even feel guilty if they feel happy. They feel shame that they feel happy. They don't deserve to feel happy because their loved one that they care about, let's say, is not having a good day. There's also increased risk for substance abuse for caregivers. And again, this substance abuse during COVID with caregivers, with everybody being in the home, this increased considerably. All right, so a little bit about stress before we get into the components of stress during COVID. Stress is basically any change where you have to adapt your response to it. And when you don't adapt your response to it, it's kind of like you hitting a wall, and this is basically when stress occurs. There's 3 main components of stress: physiological, cognitive, emotional, and behavioral. Physiological are things like shortness of breath, racing heartbeat, feeling sweaty, feeling clammy. Cognitive and emotional are exactly what it says: thoughts, feelings, images associated with perceived danger, feeling out of control, and then behavioral are the actual responses. So anything I can see, if I'm videoing you, if I can see it, it's a behavior. If you're scared, that's an emotion. I can't see it with a camera. But if you're running, I can see that. So that's a behavior. So the way that these things interact is what develops stress for us. So the physical, I already talked about this: racing heart, grinding teeth, increased blood pressure. Thinking. These are all the things that go through our mind: worry, memory problems, confusion, feeling out of control, difficulty making decisions. Again, all of these things escalated during COVID. So again, they're there before, and then COVID came and all of these things heightened. Emotional things like, I can't do this on my own. I'm not a good wife, mother, sister, brother. I'm angry at my spouse. I'm angry at my child, my parents. Feelings of resentment, feeling extreme fatigue and agitation at the same time, which is a terrible feeling, especially when you are home and you can't get out to get some respite, or the people in your house can't get out to give you a break because of COVID. So obviously that leads to increased irritability and anger, which is also where the substance abuse increase came in, and also the increased rates of child abuse and domestic violence. So behavioral, again, things that we look for when you're dealing with stress and anxiety: withdrawing from others, which during COVID was difficult to piece out because you can't be around people. So what I would do is I would look for things like bathing, getting dressed, eating. Are you doing things in the house like cleaning like you normally would do, your laundry? Are you putting decisions on hold that you normally would have done? Are you sleeping more or sleeping less? Are you using more alcohol, using less? So I couldn't really use what I would normally use to assess any behavior changes because of COVID. So I had to look for things that were kind of more home-based and more day-to-day activities of daily living type tasks. So warning signs of stress and anxiety during COVID that are important to look for: if you feel the need, and this is from a caregiver's perspective, if you feel the need to hurt or yell at the person that you're caring for, if you find that you're depending too much, like I said, on alcohol or drugs or prescribed pills, I just want to make sure that I mention this. Substance abuse is not just alcohol and recreational drugs. Oftentimes in a caregiving situation, or when you're dealing with an illness, you have access to certain medications. And this is where kind of taking more than what's prescribed to you comes into play, because this, a lot of times as far as substance abuse goes, not only gets overlooked, but oftentimes isn't necessarily viewed by many people as an addiction problem. So again, how do you assess for depression and anxiety in both caregivers and people with epilepsy during the pandemic? The ADLs, or activities of daily living, which I spoke about: bathing, eating, sleeping, and then things like shopping, bill paying, cleaning, following up with appointments. Are you missing your doctor's appointments? Are you missing virtual appointments? Are you not paying your bills? Things that you can do from home, but that you're not following through with. Also keep in mind that depression and anxiety is going to look different based on gender. Men and women tend to deal with their depression and anxiety a little bit differently. Males tend to get diagnosed a little bit less, not because the symptoms are less, but just because they tend to reach out for help less, although that is changing and has been changing over, I'd say, the last 10 to 15 years. They're more likely to self-treat, meaning they're more likely to use alcohol and drugs, and they have fewer support people because they don't tell as many people. So not as many people know. So some more signs and symptoms so that you know what to look for in yourself and in your loved ones: sadness and crying that won't go away, that's disproportionate to the context. So obviously during the pandemic, if you have stress, if you have anxiety, I am sure there are times where you broke down and cried. Completely normal, appropriate to context. It's when you're sighing and crying and sadness don't go away, when your reaction to situations is disproportionate to the context. So increased irritability, ongoing fights with family members and friends. And I don't mean your standard, bickering that goes on constantly every night at dinner. This is something that would have been a notable increase since the pandemic started. There's no break from it. And let's say your child drops a dish on the floor. Normally you tell them, be careful, don't do that. what this is saying is that maybe, you take the dish and you throw it against the wall, or you scream at them, or you send them to the room, or you do something that you wouldn't normally do in response to that. Physical sickness, this is the big one, because this can get confusing when you are already dealing with another physical illness, because it's hard to separate the two. But ongoing headaches, digestive problems, and chronic pain are three major things that occur when there is a ton of stress and anxiety and depression in somebody. So it's very important to kind of take a physical inventory of yourself and determine whether these symptoms are more likely due to stress and anxiety of the pandemic, or due to something else, because you'll treat them differently. A call to your neurologist or your gastro doc can manage those symptoms, but if it's something psychological that's going on, you want to make sure that you address that. So it would be something that's above and beyond, or something that's disproportionate to the context. Some things that you can do during COVID to help manage these symptoms. PMR is progressive muscle relaxation. I do this a lot with my patients. Breathing retraining. So making sure that when you breathe, your stomach is filling up, and when you breathe out, your stomach is going in. This gets more oxygen to your lungs. Guided imagery, proper nutrition, exercise. Now, exercise during COVID, we had to get creative. I'm a tennis player. I play tennis 4 times a week at minimum. I couldn't do that. So I had to improvise. So I don't work out. I hate working out. So I found classes on Zoom that were kind of workout classes, just to give myself something to do. And I did them on Zoom. So we had to get creative and modify these things, or maybe just take a walk up and down your driveway. You have to take and this was very important for people, your pre-pandemic routine, and modify it as much as you need to during COVID, but make sure that there is still some bridge between pre-COVID and during COVID, because you want to maintain as much of your pre-pandemic routine and structure as possible and as safe as possible. Scheduling of pleasurable events. Again, this may need to be modified. Let's say you had movie night with your girlfriends every Friday night. You can't do that now. So watch Netflix together on Zoom, or FaceTime and watch a movie together while you do that. Different types of behavior therapies, cognitive behavior therapy, acceptance and commitment therapy are great ways to manage anxiety and depression. That is how I practice. And it's really about sitting with discomfort, tolerating it, and not doing things to get rid of it, because that makes it worse. And medication, again, medication is a personal preference. If you find that during COVID, your anxiety and depression are getting too much for you, it's important that you speak to your neurologist first, because you want to make sure that any type of antidepressant or anti-anxiety medication does not interfere with your other medications that you're taking. So I already spoke about this. The other thing that's super important is, because of the lack of socialization and social distancing and restrictions that are in place, and because of compromised immune systems, it's very important to keep communication open with your physician. Ask questions, email them, record important information. If you think you'll remember it later while you're driving, you won't. Write things down in your phone. I have my notes section in my phone. I write everything down in that. Bring family members with you to appointments, or have them sit in on your Zoom calls or your FaceTimes, because in general, we're anxious at the doctors. We don't remember everything. During a pandemic, we're even more anxious. So try to have somebody with you, or take as many notes as you can. You want to also, as I said, maintain your prior schedule during the pandemic. So it would be very helpful for yourself, for caregivers, for family members, to make a list of all the not just daily routines, but all of the things that have to get done. Doctor's appointments, medications, what times, what dosages, everything that you do on a day-to-day basis, it should be written out somewhere, because when stress hits, we forget. Our concentration and our memory is the first thing to decrease when we're anxious. So make sure you have everything written down. Our brains tend to take shortcuts during times of stress. Pandemic is definitely a time of stress. So make sure you write everything down, even if it seems redundant. Your brain will thank you later. Use all aspects of your support network. This does not have to be just family. It does not have to be friends. Use your neighbors. Use your college roommate that you haven't spoken to in 10 years. Use as many people as you have access to. When you make your list of things that need to get done, depending on your stress level, depending on whether you have COVID or not, depending on where you're at in your epilepsy diagnosis, identify tasks that are easier for you in that moment to do so that you feel a sense of mastery, so that you feel that you've accomplished something, and delegate the others. Some people have difficulty delegating tasks to others because they like things done a certain way. I get that. However, you want to make sure that during added times of stress, like a pandemic, you delegate where you can, because the last thing you want to do is become overwhelmed, because then the stress affects your immune system, and if your immune system's low, COVID, and it's just this big vicious cycle. So delegate where you can, do the things that are easy for you so that you gain a sense of mastery. This we already know, but keep an emergency contact list with you at all times, and respite. You must, even though we are in a global pandemic, you must find time. This is both for people with epilepsy and their caregivers and family members. You must find time to take care of yourself, whatever that looks like for you. All right, so I don't know how I am on time, but I'll get through this part really quickly. Because things changed drastically as far as socialization during the pandemic, family visitations, family vacations, celebrations, holidays, traveling, everything had to be revised. So what I recommend for people in general is to find the things they can control during this uncontrollable time in our lives, and zone in on the things that you can control, no matter how small they are. Because even if you can control one tiny aspect, it gives you this sense of calm, it gives you a sense of mastery, and that is so important because it helps to reduce stress, which helps to reduce, feeling sick, which helps to reduce not compromising your immune system, and on it goes. So it's so, so important. Always look for the things that you can control. As far as planning during the pandemic, this was really difficult to do. And for people that tend to be planners, this was something that I had to get used to. This was something that a lot of my patients had to get used to. And for people who have epilepsy, there is a lot of planning that has to go into some of the things that you do on a day-to-day basis for safety reasons, or for medication reasons. And so when you can't plan ahead, it does take a toll on your day-to-day. So again, this goes to look for the things that you can control, look for the things that you can plan ahead of time. So I put in here, if you watch a TV show every Friday night that you scheduled, or you scheduled an outing with friends every Friday night, instead watch a TV show with them on Netflix. Do something. Maintain the socialization aspect. You can control that. We can't control how we do it, but we can't control that we can't go out, but we control how we do it in our household. And so you can plan for a Friday night because you're doing it in a safe environment. So it's important to plan realistically, plan safely, and keep as much of a routine as possible and maintain your socialization. This is the big one. Do what is best for your family. There is no right or wrong, and what's best for my family is not going to be what's best for your family, and so on and so on. So be careful of the inner judgment that you're placing on yourself when you see another family who has someone who is managing their epilepsy different than you, their caregiving styles are different than yours. That may work for them during the pandemic, but it won't work for you. And then this I put in every presentation I think I've ever given. Ask for help. You must ask for help. You don't want to get caught up in the catch-up game, because the catch-up game is a recipe for anxiety. Asking for help does not make you weak. Do not lose sight of who you are. If you need respite, I tell people all this, and people say they need respite, they feel guilty. I tell them, feel guilty, and at the same time, take a break. Feel guilty, and at the same time, sit in your room and watch a show. If you wait to not feel guilty, you'll never do it, and you will get overwhelmed. But I promise you, if you sit, give yourself 5 minutes, you will feel better. That guilt will subside. and build yourself a safety net. We know from years of research that the best predictor of coming out of anxiety and depression, coming out of a stressful situation, dealing with any type of medical illness is social support. That's the biggest thing. So that is something that I always recommend to people, always have a safety net. And that is it. And I'm happy to answer questions for you. And I hope that was helpful. Anything I didn't address, please feel free to ask me.
Thanks very much. That was great. We'll see about questions that come up in the chat. So I'll start you off with a question of my own. And that is, do you have advice about dealing with all those people who have their mask on under their nose? It makes me completely crazy.
As far as what to say to them directly?
Yeah, like, so I go, it's funny. So I was at the Acme a couple days ago, and there were 3 people who worked there in the produce section, actually close to where you are. You might have been there too. And they were all talking with their mask under their nose, and they were like, inches away, not feet away. So I did give them the hairy eyeball, and one of them kind of made a snide comment, because I feel compelled, in I guess a bad way, that I would like to still educate people, especially if they're working there. If it's someone who's just shopping, I think it's different than if you're actually employed there.
Yeah, and I do the same as you. I am one of those people that educates them when I see them. But it's difficult with this particular virus because of and obviously not to get political in here, but because of such dichotomous views on this, which is mind-blowing to me still. I have found, and I know I'm making a generalization here, but I have found in my experience that the people that are wearing no masks or wearing masks below their nose do not and will not ever feel the severity of this or the consequences of it. So I don't look at it as a way to convince them of anything. I look at it as a way in the moment just to get them to pull their mask up. Like, I look at it just as that in that moment, that just pull your mask up. Anything past that, I honestly, I have given up on, because I think at this point, if you're not wearing a mask, even if you're vaccinated, it's just so much more than you can do in a 5-second interaction with them. But yeah, I mean, if you're comfortable, I would say something. And whatever I feel in that moment, anxiety, nervous, I just sit with it and say it, because to me, it's better to say something than not.
Perfect. Thank you, Dr. Zuckerman, for such a great presentation. As of right now, we don't have any questions in the chat box, but if anyone does, please feel free to answer them.
I'll ask you again, Jaime, are the majority of psychologists and therapists doing telemedicine, or some doing in person? What's happening?
Yeah, so I'm still telemedicine. I have been since last March. I am hoping by this summer, I'm vaccinated. As long as my patients are vaccinated, I'm okay seeing them in my office with certain precautions in place. But most of the psychologists that I know, psychiatrists that I know, are not in person right now.
Great. And looks like we did have another question pop in. It is, how do you know, or when do you know it's time to speak to your doctor about medication affecting your mentality?
Meaning your medication for epilepsy? Okay.
Yes.
So yeah, so one of the things that I would say is, if you notice a sudden change, Oftentimes when you increase a dose or you go on a medication, and Joyce, tell me if I'm wrong with this, but my experience with this is that it's you kind of see it a little bit more suddenly than a gradual over time. But I think that anytime you feel a mood change of any type, I wouldn't wait around to determine whether it's the medication or not. I would always talk to your doctor. I think that waiting around to try to figure it out, why wait? Take care of it now. And if it's because of the medication, then you'll know sooner. And if it's not, then you know to work on more of kind of a coping strategy approach to things.
Great, thank you. And we had another, excuse me, a few more questions popped in. Another one is, how do you help children in the home that have seen a parent or loved one have a seizure?
So that's tough. So I don't work with children. However, I will answer this because I do know this much about it. When it comes to children, you never want to lie to them, even if the topic is something that no child should be able to comprehend or understand. So you never want to lie. You always want to explain to a child what's happening in a language that's age appropriate, that's appropriate to their emotional, kind of their emotional IQ, so to speak. So, I think about my 3-year-old. If my 3-year-old saw somebody have a seizure, I would explain what was happening to them very different than I would my 8-year-old, right? Or my 5-year-old. So you have to take that into consideration first. You don't want to lie, but you do want to explain it in a manner that lets them know that mommy and daddy are okay. Everybody is safe. They did nothing wrong. And explain to them that, that it depends on the age. I don't know if at 3 years old, I would get into epilepsy and illness and I don't think I would go into that. What I would probably say age dependent is something like just ensure that they're safe, because with children, they need to feel that their parents are in control and therefore they are safe. So mommy and daddy are safe, you're safe, everybody's okay. And ask them questions. Ask them, what do you want to know? What don't you understand? Because then they feel that they're part of the conversation. So that's kind of the route I would take with that.
Perfect, thank you. And I will add on, just here at the foundation, we do offer student and student trainings for early elementary school all the way up through high school. So if you're ever interested in us doing one, even for your children, we found that with the trainings, it helps the children really understand more, and they're very receptive to the trainings. But our other next question is, are you encouraging people to re-engage now that certain things are opening up? And are you seeing that patients are having trouble with this?
So this is actually very interesting. And I remember thinking this was so odd when this happens, but I noticed that, just generally speaking, my patients in general, my patients who had generalized anxiety disorder and social anxiety disorder, when the pandemic hit, they no longer they didn't want to transfer to telehealth, but they actually were okay. They were so much better when the pandemic, when it hit, when we were in lockdown, when we had to isolate. And the reason for that was they weren't really better. They just now had this mandated avoidance. And one of the things that I kept saying was, when this gets better, when we can see the light at the end of the tunnel, people with social anxiety disorder and anxiety in general are going to have a harder time re-engaging because they've been avoiding for so long now. And it's kind of like all their anxieties finally had a place to go, whereas normally their anxieties are irrational, which makes it worry, which makes it generalized anxiety disorder. But now their anxieties actually had a place to land. And now that things are improving, their anxiety, because with any mood, the more you avoid it, the larger it gets. It's like stuffing a closet. You can stuff it, but eventually it's going to just pile up on top of you. And so I found that people without high levels of anxiety before the pandemic are very eager to get back out safely. People that had anxiety before the pandemic, they're actually the ones that were better during, but now have significantly more anxiety, and they are all coming back for therapy. I don't think I have one person that has not come back that stopped coming during that time. So I found that to be very interesting. Am I encouraging it? I am encouraging it as long as it's done safely. But I also tell people you have to start very small. We have been out of our routines for a long time. And like anything else, you don't want to jump back into anything. You want to start small. You don't know what you're going to be comfortable with yet. And so take your time with this.
Perfect. Thank you very much. And another question we have is, how can loved ones support people with epilepsy that are not open to understanding and open to educating themselves?
So this is tough, because the way we want people to understand and the way we want them to get it sometimes just isn't possible. I like to take the approach. So there's a difference between people that don't get it and people that aren't willing to understand. So the people that don't get it, what I always recommend is explaining it in a way, kind of like with a child, explaining it in very broad terms, explaining to them the different types of seizures, the specific type of seizure you have, what it looks like. And also, a lot of times with epilepsy, the people around you don't want to know because it's fear-based. It scares them. They have this idea in their head of what epilepsy is, and 99% of the time they're wrong. So a lot of times education reduces that fear and that stigma, and they'll be more willing to listen. So that's kind of the approach I take with that. For people that just don't want to hear, I think the question should be reversed. Why do you keep trying to get them to get it? Because there's some people that just don't make themselves available to learn new things. And so for the sake of your anxiety and you hitting your limit, ask yourself why it's so important for you to get this particular person to get it, with the option that they just never may get it.
Great, thank you very much. Another question we have is, do epilepsy medicines have a long-term impact on memory? I don't know if it is from reading studies that saying that memory gets affected and it is perceived, but I felt that from taking 2 to 3 years of meds had an effect on my memory. Then how was it before my seizure? Is there really a long-term negative impact on memory?
Joyce, do you want to take this one? Because I'm pretty sure that there is, but I don't want to misspeak.
Yeah, sure. So, the goal of treatment for everybody with epilepsy on this call or their loved ones is to be seizure-free and side effect-free. Now, we know that that's a challenge. What we do know about memory is that both epilepsy itself, as well as seizure medications, can impact memory. So your memory can be tested. That can be tested with a neuropsychologist to get kind of a baseline, which is extremely helpful. And you can speak with your doctor about potentially changing medications. I've had the experience where I have taken people off of a particular drug and onto another one, and their memory improves. But I more often have an experience that we switch medication and the memory issues persist despite switching to numerous medications. So it is possible for medications to impact your memory, but it's also possible that epilepsy can impact memory, or just, aging can impact memory. So it's important to have it studied.
And I'll throw in too, also, and this is where I think a lot of the referrals, Joyce, when we work together through both, is depression and anxiety contributing to memory difficulties? Because depression and anxiety, again, one of the first things that occurs that people don't realize is concentration, attention, it is significantly impacted. Think about when you worry and you're kind of lost in your mind. We miss details of things. We forget where our keys are, and so it's important to acknowledge that also could be due to, in addition to all of those other things, a symptom of depression and anxiety, and usually one of the earlier ones.
Great. Thank you very much. And I believe we have time for just one more question. If you do feel the need to isolate yourself due to stress, what is the best way to go about communicating with your loved ones?
That you need to isolate, or you need time to yourself? So they're two different things. Isolating yourself, I would recommend against. Time to yourself. Okay. So time for yourself. I guess it depends on your relationship with your family. If time to yourself, how is it viewed? Is it viewed as selfish? Is it viewed as necessary? It depends on kind of how it's viewed in your family. So if you need time to yourself, again, it's always best to tell the truth, explain it in a way that the people you're speaking to will understand. Some people could just, say to their spouse, like, I'm out, I gotta go, and walk out, right? And because that's how they communicate. Or it could be a discussion over dinner. Listen, I've been really stressed out lately. It really would help if I could take 5 minutes. Do you think you could do X, Y, and Z? Why I take time to myself? So whatever communication style you have, use that. And if you feel guilty, bad, wrong, shameful for taking a break, don't wait until you don't feel those things anymore before you take the break. You have to take the break first and simultaneously feel those things, and then they will start to dissipate, never the other way around.
Perfect. Thank you very much, Dr. Zuckerman, for taking the time to present today and answering everyone's questions.
Thank you.
Great. And we are now going to move on to Rena, who's going to go over some of our upcoming events.
All right, thank you, Seamus. Hi, everyone. My name is Rena Laughlin. I am the program director here at the EFEPA. Thank you to our fantastic speakers, sponsors, and all of you out there for tuning in today. We at the EFEPA would love for all of you to stay connected throughout the year. Together, let's continue this momentum of education and advocacy by raising awareness about epilepsy, sharing our stories, volunteering, attending EFEPA events, and inviting the EFEPA to lead seizure recognition and first aid trainings for your workplace, schools, local first responders, and even for your own family and friends. We would also love to support and help you with any ideas you have for fundraising and awareness campaigns. Please stay connected with us through our website, efepa.org, and through social media. We have 2 more spring educational conferences that will take place virtually in May. We have our Pediatric Epilepsy Conference on Thursday, May 13th from 6 to 8 p.m. You can see more details and register at epilepsyinthevalley.org. For any questions, you can also email Ellen Baca at lv@efepa.org. We have an adult epilepsy conference, and that's going to be Tuesday, May 25th from 6 to 8 p.m. You can see more details and to register at epilepsyeducationpa.org. For any questions, you may email Carrie Mickna at kmickna@efepa.org. So just like today, we have terrific speakers and topics lined up, so I hope you will join us for those. We have our young adult retreat for individuals diagnosed with epilepsy who are 18 to 30 years old from May 21st to the 23rd. May 21st will be a virtual evening event. May 22nd will be an in-person day at Camp Green Lane filled with safe and fun activities. May 23rd will be a virtual day of guest speakers and topics. We also are looking for volunteer adult mentors and medical staff to help out, especially for the in-person day. So for our full schedule and to register, check out efepa.org/young adult retreat. And for any questions, you may contact Alyssa Kratzen at camp@efepa.org, or you can call her at 215-629-5003. We have 2 Walk to End Epilepsy events coming up in June. Our Walk to End Epilepsy Lehigh Valley will take place June 13th, and our Walk to End Epilepsy Philadelphia will take place on June 19th. Both our walks will have a hybrid format, so there will be an in-person and virtual elements to continue to create an inclusive and engaging walk experience for all of our community members. We encourage you to join us in registering your teams and rallying your networks to support you. To register for the Lehigh Valley, check out epilepsywalklv.org, and to register for Philadelphia, check out epilepsywalkphl.org. For more information, you can email us at development@efepa.org. Okay, we have our Camp Achieve. This is our week-long summer camp for kids diagnosed with epilepsy that are 8 to 17 years old. We will have an in-person and a virtual format to provide our camp community with a safe and fun experience. Camp will take place from Sunday, August 15th to Friday, August 20th. We are also looking for volunteer counselors and medical staff to help out for in-person days at camp, which takes place at Camp Green Lane, which is near Lansdale. For more information and to register, go to efepa.org/campachieve. And you may also email Alyssa Kratzen at camp@efepa.org or give her a call at 215-629-5003. Lastly, we run an evidence-based program called Hopscotch for adults with epilepsy. It's an 8-week one-on-one coaching program via Zoom and phone that has been shown to improve memory and cognition. So participants work with myself or Seamus Morgan as we are trained memory coaches. For more information, check out efepa.org/hopscotch, and you may reach out to Seamus Morgan at smorgan@efepa.org or call him at our number at 215-629-5003. We will also be starting the PACES program, which is another evidence-based group for adults diagnosed with epilepsy. It's an 8-week psychoeducational group that has been shown to improve individuals' self-management of epilepsy. Participants will meet once a week via Zoom for group sessions that will be facilitated by myself and Seamus Morgan. We are beginning to recruit participants, so if this is something that you're interested in, please reach out to me at rlachlan@efepa.org, or you may call me at 215-779-8828. Okay, at this time, we will be launching our second poll. So if you can take a few minutes to fill that out, that would be wonderful. And once again, on behalf of the EFUPA, we want to thank our wonderful speakers, our sponsors, and all of you for spending your Saturday with us. We hope you have a wonderful weekend.